has really led the way for us in understanding what we should be doing and what we can do in order to make a difference. And so, shall I present the award? Okay. Would you please join us on the stage? And as he comes, I do want to take a moment to really speak to his distinguished career. We give this award to someone who has dedicated their life to the pursuit and advancement of global health equity, because the person who it is named for has done such. Now, Dr. Glass is no stranger to Morehouse School of Medicine. In 2018, he joined us for our symposium entitled Global Health Equity, Envisioning the Future, where he, along with Dr. Anthony Fauci, Dr. Gary Gibbons, Ambassador Andrew Young, Dr. Erica Mendoza, addressed over 300 international and domestic global health and development experts, researchers, scientists, community leaders, and students, helping them to imagine a way forward. How could they be a part of the solutions associated with global health equity? And we honored those communities as partners in how we would co-create solutions around cultural competency and collaboration. Our recipient today, though, has had a lifelong commitment to improving health outcomes around the world. And his work has been nothing less than extraordinary. From early academic achievements at Harvard to your Fulbright Fellowship at Buenos Aires, your passion for global health has always been evident. You then journeyed to the CDC. So many people find themselves at the CDC, don't they? It's sort of like the training ground. And then, thank goodness, we're able to pick them off one by one to come into the true world of academia and make a difference. He then went to the NIH and started his directorship at the Fogarty International Center. He's done groundbreaking research himself, which is another truism, that in order for you to be seen as an expert, particularly when you're trying to endear young people to do this type of sometimes thankless work, you yourself has to be shown as one who's done that. And he's done that. He's done groundbreaking research on rotavirus and viral gastroenteritis, things that we might take for granted here in the United States, but it saves lives in other countries. He's also, though, and I think this is why we believe he should definitely be the recipient of this award. Again, I speak to building global health research capacity and mentoring countless scientists and fostering collaborations between places like Morehouse School of Medicine and the number of countries that we've had the opportunity to partner with. The legacy you've built has been one built on service, and we thank you for that. And today we are honored to not just thank you for your impressive career, but more importantly, thank you for the impact that you have had on many, not just here in this country, but around the world. It is with deep respect and admiration that we present to you the Dr. David Satcher Award. Thank you for your lifetime of service and for inspiring future generations and forcing all of us, not because we don't have choice, but because we care, to continue this fight for global health equity. Thank you. Now, you can say a couple of words now, but you don't, not give your speech, though, because you know you have a presentation, too. Yeah.
Valerie, I'm just honored. I'm a little bit speechless. I'm not often speechless except with my wife, but I'm honored to be here, to be at Morehouse, and to speak about equity and about careers and global health and how global health and local health are one and the same. And I look at this audience of people who have benefited from Fogarty programs over the last 17 or 18 years, and I see maybe you could raise your hand if you've had some contact. I see some of the mentors, some of the grantees, and I think there have been 17 fellows from Morehouse who have been part of the program, and Jonathan Stiles and Kofi have been just wonderful leaders in this, finding people and placing them in international settings, and opening their eyes to global health. So we have to get those people back and look at local and global. Valerie, this was lovely. I'm humbled to be here and honored to be receiving an honor in the name of David Satcher, who was the head of CDC just when I was about to launch a rotavirus vaccine. And as he was walking out the door, and we had been friends before, I said, 1998, and I'll mention this later, I said, David, we just licensed the rotavirus vaccine. Now that you're going to be the Surgeon General in the ASH, I need your help to put this into all American children and into children around the world. And he smiled, and within 1 year, the vaccine was licensed by ACIP. And so David was really behind this. So thank you.
Thank you. Thank you.
Okay, well, Dr. Glass, have a seat. Yes, thank you. Thank you, Dr. Montgomery Rice, and good luck with the rest of your day. We're going to continue, and we want to show a short video. By the way, my name is Barney Graham. I'm director of the David Satcher Global Health Equity Institute. And we want to show this short video describing Dr. Satcher's career, and then we'll move on, and I'll have a few more embarrassing things to say about Dr. Glass.
I chose to study medicine because of my own experience with a very serious illness as a child. I almost died. The doctor who came out to the house told my parents that he didn't expect me to live out the week, he said. But he also took the time to show them what to do to give me the best chance of living. And they must have done a great job because I survived.
Dr. Satcher was born on March 2nd, 1941, in Addison, Alabama. Inspired at the tender age of 6 that he wanted to become a doctor. After graduating valedictorian from the Calhoun County Training School outside of Anniston, Satcher enrolled at Morehouse College. In his book, My Quest for Health Equity, Satcher shares, I left Morehouse College for medical school with an attitude. My attitude was that I was expected not only to become a doctor and practice medicine, but that I was expected to be a leader in medicine, a leader in the quest for health equity. And Dr. Satcher has done just that. A 4-star admiral in the United States Public Health Service Commissioned Corps, 16th Surgeon General, 10th Assistant Secretary for Health in the Department of Health and Human Services, Director for the Centers of Disease Control and Prevention, President, Meharry Medical College, President, Morehouse School of Medicine, Founding Director, Satcher Health Leadership Institute. Dr. Satcher has been on a mission to remove barriers and create opportunities for people to live healthy lives. An advocate for mental health parity, racial justice, and the eradication of poverty, Dr. Satcher challenges that the path to health equity rests in leaders who first care enough, know enough, and have the courage to do enough to persevere until the job is done. Dedicated to empowering the next generation of public health, biomedical science, and medical leaders, Dr. Satcher continues to be a leading voice in global health equity.
I want to make it very clear that when we talk about disparities in health, we are talking about race and ethnicity, we are talking about mental health, we're talking about sexual health, we're talking about all those areas where people tend to get left out or not have access to quality health care or access to healthy lifestyles, which is just as important. That's what the social determinants of health. The social determinants tell us that there are people who don't have access to the opportunities to lead healthy lifestyles, either because of where they live or what they have in terms of financial resources. And we have a responsibility to make sure that everybody has the opportunity to lead healthy lifestyles. And that's a part of the goal of global health equity.
Now, building upon the legacy of Dr. David Satcher and his lessons learned from 50 years of leadership,
You may have missed the last couple of sentences there, but we're going to move on to Dr. Glass's keynote address. Dr. Glass is a MD, MPH, PhD. He was trained at Harvard for his medical degree and went to the University of Gothenburg in Sweden for his PhD in microbiology. He is both a renowned public health official and public health warrior and a scientist who has been involved in vaccine development, and you heard especially for rotavirus. He started at the CDC, but has spent about 15 years of his career at the Fogarty International Center, where he helped to spread the wealth to try to make an impact on global health. He has received Lifetime Achievement Awards from the CDC, from the Consortium of Universities for Global Health. He's received the Sabin Gold Medal for his work on rotavirus vaccine development, and a number of other awards, including the Jimmy and Rosalind Carter Humanitarian Award from the National Foundation for Infectious Diseases. So he's had a remarkable career. He's a friend of Morehouse, and I'm very happy to have him giving this keynote talk and receiving the award on his journey from Bangladesh to Fogarty.
Barney, thank you so much for the generous invitation to be here. In some ways, I feel like I'm coming home when I look at the audience. And I have to tell you that despite all the training and things, I never set out to be a PhD, to do research, to work in global health, to be in I was a primordial stem cell. So, and I'm really honored to be here honoring David Satcher as well and his efforts. Do I advance the slides? Well, I started when I was in college. I took history of science. Gave me pre-med, and I learned about John Snow and the cholera epidemic in London, and the fact that here you can see the pump, the famous Broad Street pump, and all the cases that he plotted out. Really, the beginning of descriptive epidemiology, linking cholera to the pump, and then he took the handle off the pump prophetically and stopped cholera. And I said, this is one of the great diseases of all time. If he could do this in London, There's cholera in 142 countries of the world. Why can't I just go out and do that? This is the naive thoughts of a young college student. Oh, thanks. And I push it here? This one?
Yes.
Great. Where do I point? There. So I went to CDC. I joined the enterics group. My first enteric investigation was on this cruise ship. It was salmonella, and there were 800 people sick. It was really disgusting on board. I boarded the ship for a day. People were barfing all over. It was just terrible. And I did that for a day and a half, very exciting. And I said, this is fun, but is this global health? Is this how I want to spend my life? And so I moved to Bangladesh with my wife, who was just finished her pediatric training at Emory. And her director, her chief said, Barbara, you're throwing away a wonderful career, academic career, if you go off to the second poorest country in the world. Kissinger said it was a disaster case. Well, I got to this nice cruise ship in the Ganges Delta in Matlab, in the field area, which is really the homeland of cholera. And I worked on this boat for 3.5 years, doing research on the epidemiology of cholera for the development of a cholera vaccine, which is now being used in more than several dozen countries around the world, the oral inactivated cholera vaccine. So there I was, and I found when I went to Matlab that there were, here's the John Snow's pump, death's dispensary, and I found right in this area that the USAID had invested $100 million to put pumps in the 200 villages of Matlab, this district in Bangladesh, and to stop waterborne diseases. And when they did the evaluation, it made absolutely no difference on the incidence of severe cholera. The water tasted a little bit funny. It was a little pinkish tinge or reddish tinge. And we subsequently learned that it was the source of arsenic. It was contaminated with arsenic, high levels, and people in 25 years developed chronic arsenic poisoning. And to me, that was a wake-up lesson because the experiment had been done in Bangladesh, but the results were not the same as John Snow. And I learned that solutions that seem obvious, putting wells into communities, may not be right, and the solutions that are right may not be obvious. And that got us to thinking about the origins of cholera and the fact that there are environmental reservoirs with multiple phage types evolving each year, so that it wasn't just one strain being introduced like it has been in the US, but it was multiple strains in the environment. We needed a vaccine. Well, here's a patient with cholera, most severe, rapidly dehydrating disease. You lose 1 liter of fluid an hour. Here's a man who received 98 IV bottles of fluid and survived. But you can't do this in the field area where there's no IVs and solutions and doctors. So actually, oral rehydration therapy was developed. Physiology of replacement therapy, so you could give people a proper solution of salt and electrolytes and sugars, and it was quoted by the Lancet as one of the greatest achievements of the 20th century. Imagine a discovery of this magnitude being discovered in Bangladesh. And so when I came back, Richard Cash and David Nayland, with a whole troop of people on that Matlab barge who did this research, clinical trials, making sure that no one died in the course of the trial. Well, I came back to the States and with a wife who's a pediatrician, children all got IV fluids. And I was going around the world saying you should use oral therapy, but not IVs, but we had no recommendations. And so at CDC, we formulated recommendations. And when congressmen ask me, what have we learned from Bangladesh? I can immediately come back and say, well, that research in Bangladesh gave us oral rehydration therapy. I said, do you have any children in your constituency? Because the treatment that your doctor should be prescribing comes from research in Bangladesh. So it's really important. Also, in the US, Pedialyte is, go back one, Pedialyte is $6.95 a bottle, where the oral rehydration from UNICEF is 5 cents. And I was asked by JAMA to review a patient, a child who was taken to Boston Children's Hospital with severe dehydrating diarrhea. The doctor made a diagnosis. The child was a little bit better when they went home. He had a prescription for Pedialyte, and the next day, the child showed up dead. Child showed up dead, and it turned out that the mother did not have $6.95 to purchase oral rehydration therapy. Health equity. And for physicians, it's not just telling you and writing the prescription. Can you get the drug that you're prescribed? It's a whole sensitivity, and it hurt me to think that I was writing an editorial about a child who died for something that was so easily changed. Yeah. The other thing I learned was that global health is about women's health. And in Bangladesh, even though my wife could go around the field area as a Westerner, women, when they reached menarche, were taken out of school because there were no sanitary places to go. And they stayed at home sequestered. They weren't in the villages or in the markets. And they got married very early because they had no value to the family. So they'd get married early, and they'd have 2 or 3 kids by the time they were 20 years of age. And family planning programs there in red were going nowhere. And so what could you do to change this? And as I've gone back to Bangladesh over the years, at that time when I was there, $500 million in family planning, and it was not reaching women. Turns out that when opportunities came for employment and education, Mohammed Yunus with microfinance programs for women, the garment industry that employed young women in their teenage years, that the fertility declined from 6.3 to 2.3 children. So that this is now a middle-income country with a demographic dividend. So global health is women's health also, and if you invest in women, that's a lesson I learned in Bangladesh, and I keep with me today. Well, I got to Bangladesh, and I didn't know. I had never seen a case of cholera. I had never done a clinical trial. But when CDC asked who wanted to go out and do a clinical trial of a new vaccine, I said, I'm your guy, not knowing anything about it. And I got there, and of course, the trial was canceled as soon as I got there, so I had no remit. But with my wife, we looked at surveillance, and here's the pattern, and this is what we knew about diarrheal pathogens when I got there and when I was in medical school. About 6% were Salmonella, Shigella, cholera, not very common in this country. Amoeba and Giardia, also not common. And then this term idiopathic, and as a medical student, I thought that was some kind of a germ. I didn't realize it was type unknown. And over the years, we have over 26 bugs, germs, and different pathogens responsible for diarrheal diseases. So Ruth Bishop here, the only woman in this group and a real icon for women in research, discovered rotavirus. And I'm not pointing the right, discovered rotavirus about 50 years ago. And here's a patient with severe dehydrating diarrhea, vomiting, shock, and high mortality if they weren't rehydrated. My wife was totally just out of pediatrics, knew no epidemiology, but we had 100,000 patients coming in with diarrhea, and we knew nothing about them. So together we set up, and she really led setting up a surveillance system of these 100,000 patients. Now we couldn't test them all, so we picked a 1 in 25 sample, 4%, and did a full clinical exam, stool exam, and pathogen exam. And lo and behold, cholera, which I thought was the most important diarrheal pathogen in the world, was really second or third to rotavirus, which was a totally new virus. That was one of those idiopathic bugs that I hadn't heard about. And that got me to scratching my head and thinking that if I came home to the US and I studied cholera, I wouldn't see very many cases. But if I came home and studied rotavirus, this might be something that would be suitable for attention with a vaccine. So I learned lessons from global health that I learned. First was, most important thing for me, I went to Bangladesh with very little experience in pediatrics, in cholera, in clinical trials, in research. But in the course of addressing a real-life problem in the field, this was absolutely captivating for me. So if you go, and young people in the Fogarty program is exactly that, to get young people well-trained in medicine, not quite sure what they want to do, to go out and have an international experience. The obvious solutions, as I said, are not always correct, and the correct solutions are not always obvious. And we have so many non-obvious solutions that need interventions. Global health and local health are not opposites. We have the same disparities in Bangladesh as we have in Atlanta. Good human chemistry builds partnerships, and here I am. I was in a Muslim country, the second largest Muslim country in the world, but these were all my friends. There was no distance between me and our field workers. Great mentorship is essential. Implementation research. You know, at NIH, when I got there, people didn't want to think about implementation. Once you made a vaccine, it's all over, your job is done. But if it's not vaccinations that save lives, it's vaccination and vaccination programs. And if you can't get these vaccines into the field, they're of no value. And the frontiers of science, like in Bangladesh and oral therapy or cholera vaccines, may not be at home. So with that, I came back to CDC after this experience, and the head of CDC welcomed me back to run the rotavirus lab. I had been at NIH for 3 years learning lab skills, came back to CDC, and he said, I'm so happy to have you back. I told him about my work with rotavirus, and he sent me a letter saying, welcome back to head up the retrovirus laboratory. The rotavirus, retrovirus, they're almost alike, you know, 1 or 2 letters, and I realized I had an uphill battle. So I had no money, I had no laboratory, but I had 1 EIS officer, and I said, we're cheap and lazy. We have 1 person to work on this, and we have no money. What are we going to do? And so we went to data from the NCHS data, and you can see here diarrheal hospitalizations by month over a 20-year period or so. And you can see a winter spike in children from really 7 months to 2 or 3 years of age. And we learned that this spike was rotavirus. And it allowed us to assess the burden of disease and also to think that if we had a vaccine, we might get rid of that spike in peak of diarrheal disease. Also, that spike was 12% of hospitalizations in American children. So if I have 1 conflict of interest, since I've been in government for my life, my only conflict is with my wife, who is chair of pediatrics, because her remit was to keep the hospitals filled with children. And I was going to remove 5% of her children from the hospitalization, but she's accepted me, and that's been okay. And Mei Shang-ho is my first EIS officer. So we came up with a burden of disease in the US. It's not a lethal disease in the US, except there is an equity value that you can see right there, or an issue. But it's really 5% of admissions, lots of visits and episodes. Every child gets this disease in their first year of life. When we look around the world, the IOM came up with estimates in 1986 of being about 870,000 deaths a year. 870,000 deaths a year. So it seemed like an appropriate target to work globally as well. And here you see mostly in India, sub-Saharan Africa, and some in South America. Well, I worked at NIH for that 3-year interim before coming back to NIH with Al Kapikian, who developed the first vaccine, RotaShield. And when this was licensed, it was really, and it was David Satcher, who was at the helm as Surgeon General, who was in the seat when this was licensed. So I have to thank him. I had encouraged him when he left CDC, and he came right through within a year. So that was terrific. I also was called by Bill Gates, who read about the global burden of disease and said that this has got to be a priority for vaccine development, with 870,000 deaths a year that was reported in the IOM study. So I met him, and he put forth the first $100 million for vaccine development, and rotavirus was $25 million. I was an impoverished researcher at CDC with no funding, and all of a sudden I had a program funded by the richest man in the world to do research. I was overwhelmed. Well, you can't be overwhelmed for too long, because within a year of launching that vaccine, intussusception, this complication, came, and the company was so disturbed by this that they stopped production of the vaccine. And I stood there without a vaccine to promote, and I was devastated. I went back to the Gates Committee and I said, "No, don't take away my $25 million, please." And Phil Russell, I said, what do I do to keep this money? And he said, in the military, we have disasters all the time. The submarine comes up under the Japanese boat. The group goes out and is totally decimated in the field. We always say the same thing. Sir, go to the commanding officer, we've had a major problem we never anticipated. But in investigating the problem, we came up with a solution. And I think now, having resolved the problem, we're going to get to our target faster than we ever would have before. And I thought about that, and the next day I went to the committee and I said, "Gentlemen," and they were all gentlemen, I said, "We have a problem. We lost our leading vaccine. Everything we had planned has got to be rethought." I said, "But in this loss, I think there's a bright star. One is that there's only one vaccine manufacturer who had never thought about the world's supply. They were a small-time vaccine manufacturer, but now Merck and GSK and other manufacturers can come on. Second, this was a simple vaccine, virus in tissue culture. Emerging manufacturers realized that they could do this themselves. They make polio, they make other vaccines and virocells. And the world was ready for a rotavirus vaccine. Everybody was ready to accept this. So I said, because of this, we're going to have competition for new vaccines, and we're going to get to our target faster than we would have before. And consequently, the committee deliberated. They said, "Glass, go ahead," and it saved my life. A breath of fresh air when that happened. Well, 7 years later, 2 new vaccines came out in the West. A pentavalent vaccine from Merck, and GSK had a monovalent. It was recommended immediately by ACIP for routine immunization of all American children. And immediately, within 2 years, you could see reductions in hospitalizations, emergency department visits, all over. Consequences have been enormous, and it's been an incredibly effective vaccine. Here's in Mexico, we always thought that this might affect deaths. And the first evidence of death impact you can see in Mexico, which introduced the vaccine in 2007. And within 2 years, their diarrheal deaths were markedly reduced. So it was the first documentation, about a 40% reduction in diarrheal deaths in Mexico, that we could really have a global impact. Well, we set up at CDC, while waiting for the next vaccines, surveillance in 58 countries, training people from those countries, either in the epidemiology of hospital-based surveillance, very cheap, 1 or 2 hospitals in a country, taking a couple hundred kids a year and looking for rotavirus in cases with diarrhea. And it turned out that everyone, the average was about 36% of children had rotavirus as their pathogen. More important were the numbers of people, chiefs of pediatrics and laboratory scientists, to whom we provided simple diagnostic tests for $1 a dose. And they could do the research themselves, so when vaccines became available, they were advocates. And WHO approved the vaccines for global use in 2009 and 2010. So we had really a global program. And today, over 120 countries are using the vaccine. But really only half the children are using the vaccine, and the vaccine is not fully effective in low-income countries. I think with this, I'm going to leave the rotavirus story, because we're still involved in this. One last feature of this was the vaccines were quite expensive, $200 in the US. And it was a tiered price of about $15 a child in the Americas. And Gavi came in and gave the vaccine very cheap, 30 cents a dose in low-income countries for 5 years. But once you've gone through your 5 years, what does a country do? And we thought, could we make a vaccine for under $1 a dose? This is virus in tissue culture. Could we do the same? And I looked at the landscape. India was the place to go because they had the largest burden of diarrheal deaths, a large vaccine industry, and they used primarily their own vaccines. So I met a colleague in a WHO meeting in Calcutta. We lived in a convent. It was the cheapest lodging in Calcutta that they could find. So we went out for a drink, and while we were drinking, he told me about an outbreak in newborns where those newborns were shedding rotavirus. Rotavirus doesn't affect newborns. And when we followed them up, those newborns who had been infected had an immune response and were protected from severe disease. So naively in 1985, we said, maybe this could be a vaccine, but what did we know about vaccines? Well, to jump ahead, this story jumped into 20 years later when we completed a clinical trial of this vaccine, a newborn strain made in India with an Indian strain, an Indian manufacturer, Indian processing, and with CDC's help throughout. And it was highly successful, and it was licensed, and it got me to meet this guy, President Modi of India, who said 6 weeks after the trial results that this vaccine would be in all children in India during his term. So regardless of what you think about Modi, I didn't know of any other world leader who would know what rotavirus is or would bitch for a program of a domestic vaccine made that would save the lives of nearly 100,000 children. So, and there are 2 vaccines. So the lessons I learned from global health: start young and go out to the real world and have an international experience. It'll open your eyes to what you have back at home. Sustainability, training, research, partnerships are all important. Global health and local health are not opposites. Partnerships are essential, and this was all done with Gates Foundation, but the government of India invested in this project, and my colleague. Be curious, open-minded, and find your passion. I never thought I would have worked on diarrheal diseases for a career. It's the ugliest disease, maybe after AIDS, but it was be curious. Equity and access are essential to achieve your goals. And we're still trying to get more effective vaccines for low-income countries. And ultimately, take science where the problems are. So with that, I came back to Fogarty, and which had a mission to address global health issues through training for research and education, and to support the NIH mission. Well, you know, there are 27 institutes at NIH, $47 billion budget last year. I don't know what it's going to be next year. But, and our biggest partner really was NIAID, Tony Fauci. He had loads of programs in global health, but most of these other institutes were not real interested. That was not a priority. And our budget was 96 million. We were 0.2% of the NIH budget. It's been termed to me decimal dust. So we had decimal dust to change the world. So how do you do that? Well, I looked out and we looked at the global burden of disease, which deals with aging, mental health, environmental hazards, climate change, obesity, chronic diseases. It's clearly global. And so we had a session at NIH with all the institute directors, and we asked them, what is your portfolio in global health, and why is it important to the United States? What do you see in this? Well, the first was Tony Fauci, who had no problem saying that diseases and infections know no borders, and every year we're having new infections, so we have to be global. We have to have laboratories around the world that can detect and diagnose. Then we went to cancers, and at the time we looked at cancers, and Richard Dahl, the most famous epidemiologist of the 20th century and had been one of my mentors, said, you know, he wrote the book Cancer in 5 Continents and examined why cancers are different in different continents. And here you see the different sites where different cancers are most common. And that gives you an idea of the etiology and risk factors and the like. And 85% of cancers are in the low and middle income countries. Well, Dennis Burkitt was an Englishman surgeon, but an NIH grantee, and working in Uganda. What can we learn from Uganda, one of the poorest countries in Africa? And Dennis described African lymphoma. He came to the UK and met Epstein and Barr, and, which was an unidentified virus, and linked EB virus to cancer. He also linked it later to nasopharyngeal carcinoma, and my son had EB virus infection. It was mononucleosis, but he didn't have cancer. How can the same virus cause all of these 3 diseases? We have to work in Uganda to understand that, or in China to learn about nasopharyngeal carcinoma. But that was the first link of virus with a human cancer. So when the congressman asked me why we do studies in global health, I asked, do you have any patients with cancer in your constituency? And he has to say yes. And I said, you know where the link between a virus and cancer has come? No. It came from Uganda. And then when you look further, you find that there are a whole bunch of, here's the patient with Burkitt's lymphoma. Dennis Burkitt went to Sloan Kettering and took back some methotrexate in his pocket. So think of the ethics of that. He gave it to this child, and the child improved. And it was the first demonstration that chemotherapy was helpful. And it really moved the chemotherapy research along. Well, there are a lot of other viral infections that are that are related to cancers. HPV, you all know about, bladder cancer and schistosomiasis, helicobacter and stomach cancer. There are a lot of these, and there could be infectious origins of some of them. Well, in genetic disease, Francis Collins was head of the genome. He said that the US is a melting pot of people from all over the world. And if we want to understand the diseases we have at home, we have to look abroad and see where these constituencies are. And so we're all ultimately Africans, he said. And one of the most common and costly diseases in our future is going to be Alzheimer's. It's going to cost us, everyone, the risk of Alzheimer's it's probably going to affect 1/3 of people in this group by the time you get to be 80 or 85. Where are we going to do research on Alzheimer's now and find biomarkers? Colombia, this is a grant that Fogarty started with Francisco Lopera, who just died last week, and Ken Kosick at Harvard. And it was a group, a community in Colombia. And here you see 6 generations. Here's a woman who migrated from Europe in 1746. And all of these patients in black inherited a Piscium mutation. And there's so many patients here. It was a sign of a dominance, so everyone with that mutation was going to get Alzheimer's at early onset and rapid progression. Well, what's the opportunity there? It's a terrible community, but the opportunity is that the rapid progression means that you can identify people who will get the disease and look for biomarkers as they age. Something will be critical for drug development. So they actually went on to do a Genzyme trial in that community that was not successful, but the idea that you can use this, and global health is important for that. And we can look for this in Huntington's, Korea, that was the genes were identified in Venezuela, and around the world where these groups began. And finally, environmental disasters, and I told you about arsenic, and if you want to study arsenic poisoning, where to go. So Fogarty's strategy was to build the capacity of individuals, institutions, and networks to innovate in the development of technologies, to consider implementation science, which was not well respected at NIH, and advance research and prevention in the burden of communicable and non-communicable diseases, and build partnerships in research. So that was our strategic plan. When Francis Collins joined in 2008, he put onto his mandate, number 4 here, expanding research into diseases affecting the developing world. I was very worried that he was a basic scientist, the genome. What would he do for global health? But I learned that he had an early childhood experience, if you will, an early career experience. He went as a young attending to Nigeria. He went to a missionary hospital. He found patients who were 40 years old, thin, who had ketoacidosis, diabetes. But when you gave them insulin, they were cured, and they no longer had diabetes. What was going on? And he started the research on diabetes, on the genetics of diabetes, and it was because of this experience. And this lab still is working on the genetics of diabetics. That early field experience being brought home. So we have, at Fogarty, we've had all kinds of training programs. You've had some of these, but really in infectious diseases, HIV, all branches. And today, we've been able to get all of these institutes involved in research and funding research in areas of their interest. For instance, we have a program, Brain Across the Lifespan. 9 neurologic institutes at NIH have put out over 100 R01s for brain disease, everything from fetal alcoholism in babies to Alzheimer's, the infectious causes of mental health, alcohol, drug abuse, mental health across the lifespan. And we have programs at all levels of students, from doctoral students, postdocs, and career awards, and really trying to build the field with well-trained individuals who can become leaders. So it's been a great program. And this is all on the web, but HIV was our first starting point. And that really was the origin of a major emphasis on global health, PEPFAR. And so there was a lot of funding to see how we're not only take care of patients, but how we're going to train people to take care of them into the future. And here are some of the leaders. Slim Abdul Karim just got the Lasker Award for training in global health. Patty Garcia over there was the Minister of Health in Peru, and Isaac Adewale in Nigeria, Minister of Health. People who have done, John Nkangason, now head of our PEPFAR program, Bill Pop in Haiti. Despite all the craziness in Haiti today, he's still operating JESCIO and doing outstanding research and delivery of services in the community. Amazing people, and David Serwata, who described the first cases of AIDS and HIV in Africa. They were all Fogarty trainees in their day, early on. So all the major breakthroughs in HIV research have come from people who have been trained through Fogarty programs and worked in collaboration with US institutions. We haven't funded the research, which is really expensive, but we've funded that activity that has probably the best return on investment. And that activity is building research capacity and training. Well, I want to show this one picture of Francis in Uganda with his arms around 3 women. A young woman, 20, who was born with HIV, took 18 pills a day right after birth to treat her HIV, just graduated as an engineering student, and we'll go back there. Back one slide. Yeah, just graduated as an electrical engineer and is now taking 1 tab a day and has a normal life expectancy. The second woman found out that she was married, found out that she was HIV positive at her first pregnancy visit, didn't realize her husband was HIV positive, so she went into a program of the vertical transmission, and her child came out negative. She found another husband. She had 2 other kids who were HIV negative, and she's now on 1 tab a day and is a healthy woman. And the third woman is 40, and she was in the microbicide and PrEP trials as an older woman who wanted to control her body. So 3 successes of research conducted and studies conducted in Uganda that have led to the way we're taking care of patients, prevention and treatment today. That's a nice example of the impact of this research. Well, you can't have favorite children, but you do have favorite children. This is my favorite child, was the fellows and scholars. Getting young people from around the country, either in medical schools or schools of public health or academics. We grew this program from 25 medical students to over 100 medical students and postdocs. We've sent them to dozens of countries, of over 100 a year. They're mentored in the US and the foreign site. And it really is that experience which for many is game-changing. And many of these people have grown up to leadership, started in 2004. So we have people who started with the program who are now leading programs in global surgery, global cardiology, global rheumatology, global nephrology. It's unbelievable. Genetics, we've had architects, legal scholars for health law, health finance, and more. Just a few of these crazy people who signed up for the Fogarty program. Maybe you'll recognize some of them, but here, and Gigi is really in charge of your global health program. I have to smile, as well as all the others. Some are still here at Morehouse, but you have 17 of these folks. So they represent seeds who can really build these programs into the future. So Global Health Matters, we highlighted Gigi's work. A great quote, I think you said that, huh? Maybe it was just written by our editors, but lovely quote about us humanitarians. Americans have to ask themselves if we can make even a small impact against illnesses or disaster that wreak havoc in far-flung places like Liberia and closer to home like Haiti. Why would we stand by and not do anything? So thank you, Gigi, for your leadership. Innovation, we've introduced innovation into these programs, like the sonogram, which when I was a medical student was a big, heavy piece of equipment. Now is on a laptop computer. We sent a young pediatric cardiologist to Malawi. I didn't know what she was going to do. Honestly, what would a pediatric cardiologist do in a country that has no cardiology? She took a sonogram. She found all kinds of children with congenital heart disease that could be corrected in neighboring South Africa. She found high rates of rheumatic valvular disease, and she came back with a 5-year grant to Fogarty. She's now an associate professor at Baylor because she wants to stop the 300,000 rheumatic heart disease, rheumatic fever deaths in the world, and also think that we don't need surgery, but with TAVRs and with catheter-in-place valvular changes, we could actually make a difference and get rid of the rheumatic valvular disease in the future. Global health research. Barbara Diana Bianchi went to Kenya when she was first director, found 25 programs from NICH, the Child Health Institute, she was excited about, and she's really increased her investment by seeing what these people are doing. In Malawi, Satish Gopal down here on the left was a Fogarty Fellow who went to Malawi. He was an oncologist, an ID. He went to Malawi for 1 year. He stayed for 7. Mike Cohn was his mentor. And when I visited Malawi about 3 years ago, there were all of these FIC trainees were Fogarty trainees in pathology, in surgery, in epidemiology, all sorts of programs, infectious diseases, big laboratory from and here you see the laboratory of UNC, over 120 people working on those programs to the point where the country put the National Cancer Hospital next to the UNC laboratory because there was pathology, microbiology, clinical chemistry. And they had pathology, telepathology to UNC. So big things can be done by people who are just beginners. And Sikolele Moyo, when COVID came and people asked us, what have we done for COVID in the world? Here's a guy who found the new strain, new variant of Omicron variant in Botswana, not in South Africa. Trained with Max Essex through a Fogarty program, went back and had this patient who just came from South Africa, was sick, did the diagnostic and found it was a totally different strain. So early detection. Cell phone activities are terrific. In Kenya, cell phone banking came in before they had banks. And so global health using cell phones is another option throughout sub-Saharan Africa and throughout the world, including in the United States. Mental health, what a disaster globally, a key priority. It's the second most common cause of disability adjusted life years in the world, according to the Disease Control Priority Program and IHME. What can we do about it? Here's Dixon Chibanda, one of 12 psychiatrists in Zimbabwe, and he's got 12 million people. One psychiatrist for every million people. How does that sound? So he said, what can we do? Depression and talk therapy is what we could do. He's trained a cohort of elderly women to go through some standard questions, to sit on a friendship bench with people for 6 visits, and did a controlled trial, a clinical controlled trial, and found that this was impactful. It was so impactful that these friendship benches are now employed in the city of New York, among other places, and they're clinical trials in a dozen other countries. An unusual mind saying, what can I do in an impossible situation? An idea of reverse technology, of training people to sit on a friendship bench and do. Well, at Fogarty, we helped move Fogarty over $1 billion with global programs at NIH, the Medical Education Partnership Program in partnership with PEPFAR and about 14 of the NIH institutes. Data science, all of health is around data science, tracking people, following up their diseases, implementation research. That's ongoing, and it's just in the process of being renewed. And where are we going here? I've gotten lost here. I going the wrong way? Okay. Okay, well, this is reminders here. There we go. H3 Africa, human heredity and health in Africa, $180 million in grants from NIH. And people said, this is a crazy idea. Why are we going to build genetic capabilities? But you know, there are lots of genetic differences that we'll only learn by looking at diverse populations. And I think one of the first ones to think about, which has real traction and has gotten co-funding from the Wellcome Trust, is working on sickle cell disease. You know, in Ghana, 2% of the children born are homozygous for sickle. Their life, 80% die by 5 years of age. They don't use hydroxyurea. And there are new methods that were just announced, I think a couple weeks ago, to turn on fetal hemoglobin to prevent the complications of sickling. So there's a 10-year program, $200 million, to see what we can do to set up surveillance, to do clinical trials, and address this problem. Is this a problem in the United States as well? Absolutely, and it's going to be working together with a network in Africa and other countries to see how this can be done. So decolonization has been a difficult issue because we give countries very low overhead. There are lots of issues in this, controversial, and we're trying to address this at NIH, very difficult. Just in closing, this is a website that has all of the NIH funding available for the developing world. So you can see where Morehouse is and where people working in your research area are. It has data on 12 funding agencies. So it's really a roadmap of global health. And the challenges of the future, NCDs, aging, health equity, clearly critical in addressing the social determinants of disease. I think we heard that from David Satcher's. Climate change and its impact, environmental exposures, data science, communications, migration, embracing innovations. It's a different portfolio for global health than we had 20 years ago, and we have to roll with the change. So, what's the value of global health at an academic center like Morehouse? It helps recruit talented people to campus, like Barney Graham, who I've known through global health activities with vaccines. An interest from outstanding students who have never traveled abroad, who really can see something different. They develop a third eye in seeing what they see abroad and seeing how that relates to what they do back here. Skills to recognize and diagnose unusual diseases, opens your mind to different people in different cultures and different experiences. Brings schools on the campus, engineering, economics, law, business, art, architecture for the urban cities, And it broadens the perspective, creative solutions to the equitable delivery of care. So what can Morehouse do for global health? Well, I think this is what your equity initiative is all about. Really encouraging your electives and I'm always on Kofi and Jonathan to get more students into the fellowship program because they're free for the offing. And we're now excited about some other new developments. Build partnerships and twinning relations with individual countries so you have a long-term connection. Broaden the base of interest on campus and other schools. Encourage community engagement in global health. Consider lessons from global health that you can bring back to Atlanta and recognize that global and local are indeed linked. And I was thrilled to see this new announcement from Fogarty. This is after I was there, but I was pitching for this, so I feel a little bit like a grandfather, if you will, of a new, for a summer program to take students to Ghana and to Jamaica just to get them introduced to global health issues, to see the world for the different set of eyes, to travel, to get a passport, and have an experience that will encourage more students to come into the fellowship program. And so that's a wonderful new addition. Whoops. So why does global health matter? It's really a new frontier. I mean, our students are all, you can go anywhere in the world for under $1,000 and be there in 24 hours. It's the new frontier. It's really, Hillary Clinton would say it's smart power. It's good for humanity. It addresses health equities, good for business and competition, war on terrorism, and it's good for our own future. It's just the right thing to do. So here I have to thank you at Morehouse, Barney, David Satcher, Valerie Montgomery Rice. You people have all been wonderful, as well as my former fellows of the Fogarty program and your global health program, so thank you. And big changes ahead, and they're prepare for the unexpected. And I must say, I never thought I'd be up here a few years ago as a young medical student trying to figure out what I was going to do with my life. So go with the punches. Thank you so much for your attention.
Thank you, Roger. That was a tour de force. I think we're going to move on to our panel, but I hope you're going to stay a little while so people can talk to you. And I also want to let people know that this is streaming and it will be recorded. So for your networks, people that aren't here, please let them know about these sessions. So thank you, Roger. And
Thank you.
I also want to remind people that there's a QR code out the door that will give you the program and the bios and details. And so please go out and grab your digital program when you have a chance. We're next going to have this panel discussion. Dr. Bastian, global health and mental health professional, and Deputy Director of the David Satcher Global Health Equity Institute. She's going to talk with people from Partners in Health that she will introduce.
Well, good morning, everyone. It is a pleasure to be with you all. As Barney stated, I am Gilberte, or Gigi Bastian, and it is an honor to be with you all this morning for what we hope will be a really dynamic day of discussions for you. And thank you so much, Dr. Glass, for kicking us off with such an amazing reflection on your journey and how many folks have been brought along on that journey. I'm honored to be among those who've benefited from your life's work. So it is my pleasure at this point to introduce to you one of the organizations that we really admire in the area of global health, what you will learn and hear echoed throughout the day is that global health is not a me thing, but absolutely a we thing, right? The challenges that face us as a global community are far too complex for any single entity, single nation, single discipline. We absolutely have to bring forth the best of what so many of us do to have any hope of advancing this audacious vision of global health equity that we have in our sights as our goal and mission. And so we've had the benefit at Morehouse School of Medicine in our global health work of partnering and collaborating with some amazing organizations, as well as organizations we've admired from afar and really look to as standard bearers of how we would like to embody the values that are so critical to advancing global health equity. And Partners in Health certainly reflects one of those organizations. I'm really excited for you all to have an opportunity to hear more about the amazing work they are leading, which, and I think they're a force not only because they began that work in my home country in Haiti, but have expanded and are really continuing to advance critical work in global health. And so what we'll do is we'll begin with a brief overview to sort of introduce folks to Partners in Health's work and scope, and then we'll move into a conversation and dialogue. So I want to welcome to this stage Margaret Wooten, who serves as Senior Development Officer for Partners in Health, as well as Mark Julmis, who is the Chief of Clinical Systems Support. These two are forces in their own right in terms of what they do. You just heard from Barney how you can each access the digital program where you have an opportunity to hear and read about their biographies and the amazing base of experience they draw from. But in the interest of time, I want to go ahead and get right into our discussion. So without further ado, Margaret, off to you to tell us more about Partners in Health.
Wonderful. Is this how I advance the slides? Perfect. Good morning, everyone. I'm Margaret Wooten, and I am so excited to be here with you this morning. Thank you so much, Gigi, and the incredible team at Morehouse School of Medicine for inviting us to be a part of this. I thought I could start by grounding our conversation in a little bit of context and background about PIH, but I also did want to flag, I'm a fundraiser, I'm not a medical expert, I'm not a doctor, not a nurse. My role is to work to build communities of support that help to resource our care delivery sites. I see myself as a connector, so super excited to talk about opportunities where we can partner. But all difficult questions should go to Mark because she is brilliant and an expert and definitely the person that you want to hear from. But I will start with this quote. The idea that some lives matter less is at the root of all that is wrong in the world. I wanted to start here because I think that it really is what lies at the heart of who Partners in Health is, what our mission and ethos is. These are the words of Paul Farmer, who co-founded Partners in Health and passed away in 2022. But his words continue to guide us, particularly around rejecting the limitations that we often place when caring for the world's poor. Limits that we would never place on ourselves or on our families. But Paul's belief was radical but straightforward. Drug prices, patents, policies, everything can change if we focus first on how we treat one another. So 3 decades ago, we were formed to support the work started in a small rural community in Kanj in Haiti's Central Plateau. At the beginning, Zami La Santé, which is Haitian Creole for Partners in Health, the clinic cared for a few hundred patients. Today, they care for a population of 1.3 million, and they're the second largest employer in Haiti after the government. Our work in Haiti continues to be the lifeblood of Partners in Health, particularly during this time for the country. In addition to our work in Haiti, Partners in Health now works across 11 countries, from sub-Saharan Africa to South and Central America and Navajo Nation. We serve 8 million people a year through care delivery. We work in places that are hit hard by disease like HIV and multi-drug resistant tuberculosis, but our support goes way beyond the burdens of a specific disease. In each location, we work in partnership with the community. We collaborate with ministers of health to advocate for stronger healthcare policies and financing, working flexibly and responsibly through all dimensions of the health system. And we stay. So the impact looks like a staff of 19,000 working worldwide doing critical life-saving work. We're made up of drivers, of doctors, of activists, nurses, educators, researchers, fundraisers, and community health workers, and 98% of our staff come directly from the communities that we serve. It means 68,000 facility-based deliveries, 32,000 mental health visits, 2,600 Haitian children treated yearly for malnutrition, 44,000 people receiving HIV treatments annually, and 2.2 million home visits conducted by community healthcare workers. Through it all, PIH has kept patient care at the center of its work and fought for healthcare as a human right, both within individual countries and the halls where global health policy is created and decided. PIH's work is really focused across 3 strategic pathways: to strengthen and build resilient health systems, to educate the next generation of healthcare workers, and to ensure the health of women and children. So as those of you in this room know, half of the world lacks access to essential healthcare services. System strengthening remains the most important component in mounting a response to future pandemics and meeting this goal of universal healthcare. We provide access to healthcare for our patients and help to scale our impact through government partnerships. The second piece of this is that we also train global health professionals and leaders who will deliver high-quality health services for all. We expand medical specialization through clinical residencies, undergraduate teaching, graduate medical degree programs. We commit to decolonizing global health education and building stronger local global health workforces. And then every day, more than 800 women die unnecessarily from complications related to pregnancy and childbirth. Over the next 5 years, we've committed to deepening our commitment to providing comprehensive care for women and children around the world. Our work will encompass gender equity, the prevention of gender-based violence, family planning, and oncology, and will elevate women, children, and adolescents as agents of change within their own lives, communities, and health systems. So in summary, Partners in Health work side by side with our friends and colleagues at all levels, whether they're community-based, local health authorities, or global health advocates, to deliver the highest quality care. We take our best practices and conduct research to demonstrate our impact and to educate current and future leaders. We're an organization that is diverse, nimble, and rises to the challenges that we encounter with optimism, compassion, and tenacity. So I hope this was helpful. I'm super excited to continue the conversation with Mark and Gigi, and I'll pass the mic.
Thank you so much, Margaret. So you will now understand why we thought it was so critical that we ensure that you're introduced to this amazing organization and the work that they're doing, but wanted to have an opportunity to really bring to life some of what you've heard in terms of the approach, the ethos, and the values at the heart of what Partners in Health does. And what we've learned in our work at the Morehouse School of Medicine and Global Health, and what I know is very strongly aligned with the work that you do at Partners in Health, is how critically important it is to invest in systems, in health systems, which includes how we work and partner with community to ensure sustainable impact in this space. So I'd love to hear from you if you can share how Partners in Health goes about ensuring community can really be centered in the work that you do and to lead the innovations and solutions in the spaces that you work.
That's not hard at all. Hi, everyone. I don't know why I bring notes. I know this by heart, but you put me on a stage and I forget everything, right? Community is center in everything that we do. Excuse me. It's center in everything that we do, and that's a key thing. Has anybody have ever met Paul Farmer? I can tell you when I first came to Haiti, well, not to Haiti, I was in Haiti in after the earthquake, but when I first joined Partners in Health, he made it his mission to really have a chance to talk to me and say, I don't need somebody that's going to be in the office. And that was his thing. The whole point is, if you're going to get to know about the community, if you're going to make an intervention, you need to get to know and work with the community and really believe and be part of the community. From our history was based in the community. From what Paul saw in the Central Plateau, what was happening with the displaced people that were in the Central Plateau with Father Lafontaine, it was all about the community members going directly to home visits. And that's why we sort of coined the term accompaniment model. It's walking together with the community. We're not from one facility or one institution where they're coming to us. The work that we do in maternal child health, the work that we do in HIV care, TB or MDR-TB specifically, has all its work. It's in partnership together with community health workers. A lot of the plans that we put in place when we're talking about, we're a partner, true to our name. We work with ministries of health, local government, but also, so at the table, it's not just us making a decision, it's what is coming from the community. I can tell you the majority of our workforce in Haiti specifically is community health workers, as we shared before. They're the ones that tell you, no, that's not gonna work. And they were like, okay, then let's get back to the table. So I can go into specific programs that we're doing, and it's based on what the needs are, the felt needs, what they're telling us back and forth. And I could share some of the things that came from the community specifically.
Absolutely. Would love to hear about one of those examples of an initiative where that community input and guidance has really led to some successful impact.
If you think about it, even if I could go back a little bit more, if you're thinking about during the time that COVID hit more recently, there were some, what was spent out or what was shared in Haiti, and especially around the COVID vaccinations. I'm going to talk about that. Haiti received a certain amount, and it was limited with a lot of limitations on what we can do for the COVID vaccinations. And then what was asked was we need to go and, first of all, vaccinate certain medical professionals and then expend it to the community. What was given to, again, what was given to some organizations was funds to go ahead and share with the community. And the community is telling you, specifically community leaders are saying, you need to go house to house. People are not going to do uptake. It's a new vaccine. This is not something they really believe in. You need to go house to house. And the community really advocated for that and saying, you have to do the radio spots. You have to go home to home. You have to have people that look like them. When I say look like them, it's not because I'm Haitian or I'm from there. Look like them from their community, that they know somebody there that's going to speak to them, that they can ask questions. And that had to change. And at the same time, we took what they said and went and advocated on those that were donating and saying, you can't just have a half program and saying we're going to do vaccinations and give it to some larger organizations that's going to do the traditional things rather than working directly with the community members, the local community leaders, the community health workers that's telling you, this is the path. This is the community that's being hit more. Let's go down there. Walk a mile in my shoe with me, and then you'll see the impact.
Thank you so much for sharing that. I can relate to so many of the experiences of being humbled by communities in Haiti because our folks are not shy about letting you know, where are you going with that intervention? Like, how's that gonna work? And so critically important to take that feedback and to work it. Yet we know the challenges from a fundraising perspective as you speak to, right? So Margaret, maybe you could share with us what that looks like in terms of Partners in Health's engagement of the funding community to help them understand and make the connection of why doing this work in the most effective way may require moving in unconventional ways and in ways that center intel and input from community and key partners.
Yeah, that's a great question. I was also just to add on a couple of other examples of how we've seen community involvement lead to more successful initiatives. One of those, I had the opportunity to visit our PAH site in Navajo Nation last week, 2 weeks ago, and they have something called the PFACS, which is the Patient and Family Advisory Council. So it's made up of cancer survivors, cancer caregivers, and they really are the ones that are shaping COPE's cancer initiatives. They offer feedback on any kind of research or outreach activity. They're building the materials that we're using in community education and support. And so I think that that's such a good example of where we're dependent on the community, that we're centering the lived experiences of people to kind of shape our initiatives and programs. And then the other example I thought of, Mark, was we have Casa Maternas in Mexico, which are maternal health centers, but at those health centers in Mexico, midwives and doctors and nurses are working hand in hand and really combining elements of traditional medicine, or traditional medicine with kind of modern medicine as well. And so I think that's another kind of beautiful example of building trust within a community, especially for women that have experienced obstetric violence in healthcare systems. And so I love kind of both of those examples.
Can I add one? I'm so happy you said that. One of the key things is also working with traditional birth attendants, the matrons that we know. And a lot of times they're on the fringe, they're on the outside. So a lot of our countries that do have some of the maternal health centers, we're trying to really see how do we incorporate the matrons, the traditional birth attendants, within that birth as part of the care delivery team, rather than saying this is the only way to go. Yeah. That's not true. Even so much so, how do you incorporate traditional beliefs, working with traditional healers, so that they're also part of the care delivery cycle? So that's something our psychosocial team is working on together. That's something that we have, we're socializing our clinical team. So it's not, this is the only model, medical model we're going to follow, but how do we incorporate the beliefs, the traditionals, the practice, and the practitioners within that medical model, so it's not either you or me. And that puts our patients within a bad situation a lot of times. They might not seek the right help or not tell you what other treatments they're receiving. Yeah.
And then just really quickly on the funding side, I think that at PIH we talk a lot about decolonizing global health, but we also talk about decolonizing philanthropy, which is probably its own conversation that we could have and spend an entire week on. But one of the things at PIH that we've been talking a lot more about is how are we messaging and talking about PIH to diaspora communities within the U.S. So, spending time engaging the Haitian diaspora or the Peruvian diaspora, spreading awareness about what work is taking place that would be interesting to those communities, and then how can they be involved as funders and supporters of this work, because we want our funding base to be as diverse as the communities that we're serving. And so I think that that's a challenge and something that we're kind of talking about and improving on, but it's really interesting work to me. So.
Thank you for sharing so much about that. And to that point about diversifying, all of the players involved in moving this work forward, it's been great to hear about the incredible and aligned work that you're doing around community health workers and navigators, whether it's in Mexico and Haiti. Yet also you referenced this important work that you're doing in educating some of the technical professionals in these spaces as well. So can you share a bit more about what Partners in Health has been doing in that lane around medical education and preparing that side of the workforce to address the need?
I think it all goes back, thank you so much for that question, I love it. I think it all goes back to, and I have to keep referring back to what Paul says about working in social medicine, making sure that we understand from the perspective of the patients. We actually have, how many medical programs? We have 11, is that? Residency and fellowship programs now. So in that, the residency and it's all built in the social medicine model. That's a key part. It's not just to learn, but are you learning not just from are you learning from the community? Like we say, the community members, our patients are our teachers. Our patients are our bosses. In the medical residency program, and if I could go back even after the earthquake that happened in 2010, one of the big things that we were able to open was a 300-bed teaching hospital. Even a little bit after that, we actually had the family medicine residency program, which received ACGMEI accreditation a couple of years ago. And this year, coming out of that, let me explain a little bit about that. We built a 300-bed teaching hospital where everybody told Paul, that's ridiculous, right? Why are you trying to build a hospital after an earthquake that just happened? And he said, or a teaching hospital, but the whole point was looking at what's going on in the future. He's like, this is the time that we actually need it. We need a hospital that can respond to this kind of, this massive trauma that's happening. We built out in a Central Plateau, not in Port-au-Prince, where a lot of the needs are within there. And in these medical residency program, one particular, and I would say we just received last year ACGMEI accreditation, which is it is our emergency medical residency program. That was birthed because of what happened. And so it is the only emergency medical residency program in the country for now. And right now with that, and even after the next earthquake that ended up happening in 2021 birthed the orthopedic residency program based on a need. So what happened in 2021, the beautiful part was those residents that were trained, the emergency residents, the fellows that we had, those that went out, the anesthesiologists that we had, the nurse midwives that were trained in the programs, they were the ones that responded in mass to the earthquake that happened in 2021. You didn't have, so on that flight going over to the south to go ahead and provide support that we're doing the emergency care and every emergency that really happened after that, the fire that happened in Cap-Haïtien. So we had our physicians, our nurses, our emergency team are the ones that responded. So the aid came from within. And that's on one aid. And at the same time, again, bringing back the the social medicine part, one of the big part of our program is you go into the community. You don't have the community come to you. So you have to really walk a mile in the shoe of the patient. So we do home visits. One of the things, and I'll talk about J9, but I'll hold on if there. But I get really excited because our program, actually, if you looked at our residency, unfortunately, prior to this crisis that Haiti is going through, we had about, 88% of our residents that graduated the program stayed in the country.
That's incredible.
Stayed in the country.
That's incredible.
And served within, a majority of them served within other partner in health. And we are a Ministry of Health Facilities. When we say partners in health facilities, they're all Ministry of Health Facilities and served within that. So we had our residents in the South, in the North, and anywhere you could think about, they stayed. And that's a big part. Right now, we're still at about 77% of residents that are still staying within the country. It's dropped significantly, but we still have people having the heart and willingness to say, this is my community. And so it's not about you receiving this prestigious education. It's about, do you understand the reason you're receiving this prestigious education?
Thank you so much for sharing that. Morehouse School of Medicine, sound familiar in terms of home growing our own for the work that they do here in the state of Georgia and in the U.S. There's so much power in drawing from the talent and the assets and the resources that are right there in community that for too long have been overlooked and not tapped into in the work that we do at Global Health. So it's great to hear about that. You've alluded to what you all have had to do in response to the 2010 earthquake, what you've had to do in response to the 2021 earthquake. We all are familiar with what Haiti is steeped in right now. This is, unfortunately too common of a reality in global health that the work that we can present about, the work from clinical trials or more translational work that's happening in communities is often happening against the backdrop of really turbulent times and disasters and crises. Can you talk a bit about how you continue and stay the course through those turbulent times and what you've seen in PIH's ability to sort of continue to co-create with community solutions even in the most sort of unstable and unpredictable times?
Yes, thank you. It is, I'm not gonna lie, it is the most difficult time that anybody has gone through at this point. There's no precedent for it. I have to reach back this is not just Partners in Health, this is reaching out and working together with the community, other facilities, community members and so forth. We had to be nimble and flexible, and one of the things I have to say is our team, our staff, because this is not just a job for a majority of us, and I tell them I'm bathing in the Kool-Aid almost every day, it's a mission. A lot of our staff sacrifice, even when you tell them don't go into danger areas, they say, but the patient. It's not that we encourage it, but that's the ethos that everyone has is but the patient. Right now, unfortunately, we've had to modify. We have about 17 facilities across Haiti, specifically in the Central Plateau and the Artibonite area. The Artibonite area has been having major issues even before what you see right now. What we had to do is we have not closed any of our facilities. At times, we had to reduce services for the protection of staff and patients. We have difficulty getting materials into countries, specifically because a lot of our materials are imported in country, so we have difficulty. So we had to find alternate routes. We had to increase security around when we do have our materials imported in country. Sorry, I can't go in specifics because it is still an ongoing situation, so we do have to protect the way that we are modifying some of our ways to be able to get materials to our facilities. What we are looking at is, or we have started a process of building additional warehouses in different areas so that we can have a quote unquote, for lack of better, a stock, a little bit more of a buffer for time. So if we can't get the materials to our sites in time, at least they have a little bit more time. What we've increased was communication between other facilities, our facilities and other facilities around the country, so that what you have is a community of practice, where this community practice really says, hey, I may have, specifically going down to fuel, a lot of times is, I have 1 day left of fuel, what can we share? And so we do have a daily monitoring of our fuel capacity. In this daily monitoring, and it helps us mitigate and saying, hey, we might have 3 or 4 days left or a week left, let's start reducing some services. What does it mean to reduce services? It's not patient care services. What we're saying is reduce lights. Where you had that AC, you're not gonna have it today. You know, reduce energy consumption. What do we need to do to scale back so that we make sure that we have the materials that we need to keep it going? The additional storage of fuel. So we strategically place fuel in different parts of the areas that we serve so we can get better access to some areas. We've also invested in solar. We started before, but it ramped up even more in solar energy. We've did an evaluation on all of our facilities. Mir Ballet facility, our biggest hospital, a 300-bed teaching hospital, has, we just completed, or in the process of completing our solar, our refurbishment of the solar panels that are there to be able to increase our energy efficiency. We are, oh my gosh, there's so much. There's so many ways unfortunately for staff, one of the big parts where, because of the difficulty of getting transport, and we did not want staff to take the local transport on the road because they're at risk, and we've had staff kidnapped, is we had partnered with UNOPS, which is a UN helicopter, where they would fly our staff to the Artibonite area or fly our staff to the Cap-Haïtien, where we'll drive them down to the Central Plateau. What we had was staff modify their time rather than going up and down every day, have them stay for 2 months, 1 month, 2 months, or 3 months, live on site, so that way we have less turnover and less risk of them being within that. What we had to do was move some staff members from more critical areas that lived in the area so that they're not just thinking about the patients, because they're minors and their families. So we also have to see what can we do for family members. So there's a lot of modifications that are taking place and a daily discussion of where are we now, where are we now, where are we now. And also saying with our international operations and our local operations team, is also looking at what are the best solutions. Like one thing we're looking at, heat stable or medications or supplies for specifically for hemorrhaging. How can we do on this end to say, how can we provide more stability in that? Can we look at medications that have a longer shelf life? Can we look at, so it's a complete constant evaluation and constant communication to make sure that we have the staff, the stuff, the space, and the systems in place to continue working.
Having to stay nimble and roll through, as you said, unprecedented times, right? We're seeing not only in Haiti, but if you think about the situation in Sudan and, monkeypox outbreaks, there are constantly these challenges and curveballs of unexpected things that can really make it a challenging scene. As we sort of come to a close with our conversation, I'd love to hear what gives you hope in global health right now, or what you would love to see in how we're able to bring about healthier communities really around the world. What keeps you inspired in the work that you do?
I'll go first because I want Mark to have the last word. But I think as a fundraiser, so much of my hope for kind of the global health landscape and community is how important partnerships are. You know, back to Gigi's point, you know, this is something that has to be approached through coalitions as a we. And I think about, you know, the value of partnerships with places like Morehouse, where they're in School of Medicine, where there is such a breadth and depth of experience that we should be learning and growing from. I think about partners as a fundraiser. I think about partnerships with funders who are passionate about this work and want to resource those that are on the ground doing it. And I think about the partnerships that we should be establishing with community members, really allowing lived experiences to be driving the kinds of interventions that we're recommending. And so I think that's kind of where I think about these things, but I'll pass it to Mark to give us an inspiring word.
Don't. I am hopeful, I would say, every day when we talk and work with our team on the ground, because one thing that we tend to say is don't complain, come with a solution. We'll start off with complaining and be righteously upset, right? You were like, why is this, and just go on there, like, and then it comes out and what are we gonna do about it? And how we're gonna work through this. And it's not just from leadership or the clinicians and so forth. You will have your patients coming to you and just upset up saying, I can't get the help that I need, or what's going on here. And then what you have is enough people, and it's not just clinicians, it's from every part of the organization, because everyone is part of a solution. And I love what was said earlier. I believe I wrote it down. Equity and access are essential. And so when equity and access are denied or not as easy, then we have an issue right there. I will tell you, one of the things that we have, even as we're discussing, I'll throw out maternal child. In one of our countries in Sierra Leone, we went over there earlier this year, and one of the things that came now as we were discussing opening a new maternal center of excellence, it's not about the shiny building. What one of the clinicians said is, you know what, we're having a lot more renal involvement with our patients, and we're having a lot, and they're very young, we're having a lot more cardiac involvement. What's going on there? So now it's sparking and saying, what's going on there? Here's the questions. Let's dig in deeper. What's happening here? To Haiti, where we developed the J9 program, which is Journey to 9, which is an integrated maternal child health program. That started because we are seeing not just the high maternal mortality, but the obstacles that lead to the high maternal mortality. And then there's enough complaint there that you said, let's walk a mile in their shoe. Literally walk miles in their shoe to see each of the obstacles, sit at their home, dinner with them, sup with them, drink with them. Some people take drinking a little bit more seriously, but drink with them, with our team. It's like, because then you start seeing all those obstacles, and then you ask, how can we together start addressing it? That's the hope I have, because our team consistently comes back and says, and is what are all those symptoms, or not symptoms, what are all those factors, and what do we need to do, and how do they link into each other, and who needs to be at the table for us to have the discussion. So my hope is it's never a defeatist. And if I could say one thing, and I know our time, and I'll tell you, you started off with that and saying many times we feel sometimes hopeless about stuff that's happening in global health, or we underestimate what can happen. And I want to let you know, we did the conjoined twin separation in 2015, I want to say. And this was a pivotal point in my life in global health. It's because with everything that's happened, we already had the hospital, and then we had these conjoined twin, actually triplets that had to be born, and 2 of them were conjoined. And I remember and they were like, we're gonna do it in Haiti. I was like, that's not gonna happen. I'm like, you can't do that. And I kept on looking at you can't, and all the obstacles. And I still remember Paul staying, he's like, Mark, don't tell me what we can't do, tell me what you need for us to do it. Because I kept on going, what we can't do. And from that point, that stayed in my head for everything. And that's what gives me hope. It's not looking at what we can't do. It's saying, what do we need to do this, and how do we go forward?
Thank you so much for that. We could spend the better half of the rest of the day talking to Partners in Health about all the incredible things they're doing and what they've learned and how we can benefit from that learning. But just really want to thank you both for your willingness to come sit with us. I know you're both more comfortable in the trenches doing the work than sitting here talking about it, so thank you agreeing to do that, and just want to commend the amazing work that Partners in Health is continuing to do around the world. We're transitioning into a break, so I know folks may have questions, and I welcome you to find both Margaret and Mark will be around for a bit of time, and so I'm going to encourage folks to continue the conversation as we transition into our break. But thank you both for a great conversation.
Okay, thank you. This is a great example of how programs that prosper, programs that matter, programs that last are based on love and respect for one another. So thank you for all of that. We're going to take a break. Let's try to be back at 11, and we'll try to catch up on our timing during lunch. I want to let you know there's a limited number of these copies of this book from Dr. Satcher that you can purchase at the back. So if you want a copy of this book, they're available today on a limited basis. So thank you very much, and let's go talk.
I'm saying you'd like more here, away from the break. Yeah, just standing. And then we'll do one seated as well. Yeah, just more to the side. Let's get away from the sign that says break. Yep. That's perfect. More here.
Yeah. I know.
I love a candid.
Okay, I gave you a little bit more of a break than I said, but it's time to get back. We're next going to hear from Dr. Sarah Vinson, who is the Department Chair of Psychiatry at Morehouse School of Medicine. She is a triple boarded adult, pediatric, and adolescent, and forensic psychiatrist who has a lot of energy and has a lot of ambitions for the program and for making things better. And she's going to talk to us about the inextricable link between social justice and global health.
Good morning. It's a pleasure to be before you all this morning and get to talk about this issue. And you'll hear a little bit about some of my perspectives and the things that inform the thoughts that I will share with you. And so we'll start with some key principles, a brief discussion of some global trends. I'll share some personal lessons learned in my travels and work in different places and talks there and informational exchanges. And then we'll have a call to action and discussion. So one of my favorite quotes, and this is actually on the wall in my office at Morehouse School of Medicine, is by Toni Morrison. And I feel as if I've learned as much about mental health from Toni Morrison and James Baldwin and Audre Lorde as I have from residency and fellowship, to be honest with you. But she says, definitions belong to the definers, not the defined. And when we're thinking about mental health, right, where we have this DSM and we have these criteria and we have these labels, that is a very, very relevant statement. We own these labels, we own these diagnoses, but the people that we serve may not. And it's important that whenever we go into a new situation, we think about who the definers are, what the definitions are, and go into it with a certain humility and a certain willingness to learn and to have our definitions and what we think has been defined challenged. I had the opportunity to do a keynote for the Amsterdam Psychiatric Association. And while I was doing some kind of background information there, I found that there was this psychiatrist there who was saying the same things that Dr. Shim and I said in our book, Social Injustice and Mental Health, and he'd been saying it for a really long time. So I was a bit confused about why they flew me all the way from Atlanta to say the same things this man could have said. And one of the things that his colleagues told me, one of his mentees told me was, well, sometimes people from the outside can say things that we can't say. And the lovely thing that happened was that Dr. Hellberg was highlighted in my talk, and 2 years later, he was actually one of the keynotes himself for that institution's conference. But this is from Dr. Glenn Hellberg in Amsterdam, and he said, look, for example, at the denial defined by the DSM, because in it you believe that your dominant thinking applies to everyone. And so this brings us to these ideas of cultural and structural competence versus cultural and structural humility, right? I never like to say question and answer at the end of my talks. I like to say discussion, because I understand there's always a need for bidirectional exchange, and there are different kinds of expertise. And with the competence model, right, it's well-intentioned, I think, and the idea is that you learn some things about other people who have experiences different than yours, or with the structural competence, you're learning things about systems. But with humility, there's an emphasis on the fact that it is process-based, that you bring something into that interaction as well. It's not that you are this blank slate who is right or who is the standard, but that there has to be self-evaluation, curiosity, and bidirectional learning. So this may seem like a basic question. How do you define mental health? But I can tell you that in the healthcare system, in the mental health care system, we say healthcare, but it's really sick care. And we have this emphasis on illness and symptoms and diagnosis. And I did my training at Harvard and at Emory. I did 6 years of training after medical school, and we never had a course on health. Not one. We talk about diagnoses and symptoms and therapeutic modalities and medications, but not what mental health is. So this is a definition from the World Health Organization. And whether I'm talking to lawyers or judges or pediatricians or community members or psychiatrists or rooms like this, I almost always have this somewhere near the beginning of my presentation, right? Because this is actually our true north, not the things we often focus on. And mental health is a state of mental well-being that enables people to adaptively cope with the stresses of life, realize their abilities, learn well and work well, and contribute to their community. And I welcome you to notice what's not there. In medicine and in training, we are talking about symptom rating scales and whether they're taking their medication and if they show up to clinic, right? But these are the things that actually matter. And you can notice that this definition is really contingent on relationship, and it's really placed in the context of the larger society. And so it's really hard to have health as an individual if you don't feel safe and your stressors aren't normal and you don't have a community that gives you the opportunity to realize your ability or to contribute to it. And so some bedrocks of mental health, right, are agency, safety, autonomy, and connection. And for any community, these are things to keep in mind. And there's a universality to these, right? When I was teaching PAs and nurses and midwives in Liberia, I had to go in and learn, okay, what's on your formulary? What's available to you, right? But these things, these four things mattered across the board. And so, as mentioned on the first slide, I'm the co-editor of a book, Social Injustice and Mental Health, and Dr. Ruth Shim was one of the co-editors, and this was the chapter she wrote with Dr. Compton. And she is the co-editor of the book, Social Determinants of Mental Health, and she saw social injustice and mental health as essentially the follow-up to that book. Because as we think about these social determinants that we're talking about more, things like homelessness, food insecurity, low education, unemployment, exposure to violence, we know that these things result in increased risk of adverse mental health outcomes, as well as adverse physical health outcomes. It's not that we need more studies to tell us that homelessness and food insecurity is bad for people, right? But even with the resources that we have available to us globally, sometimes even the resources we have available to us within a country that has a lot of resources like the US, we've made decisions, we've allocated resources in a way that large swaths of populations are exposed to these things that we know are potentially harmful to health. And what I wanted to say in that title, that mental health is central, is that mental health shapes how people think, feel, and behave, and how people think, feel, and behave is going to impact all of their other potential health conditions and the things that raise their risk and attenuate their risk for those health conditions. So what we see is that this exposure to these adverse social determinants of health leads to reduced options or poor choices, as they're sometimes called or framed, behavioral risk factors, physiologic stress, and psychological stress. And we end up with these adverse outcomes. Now, that question of how opportunity is distributed and how the distribution of that opportunity or the distribution of those resources is codified or how it's justified is one that lends itself to public policies and to social norms. So when we're thinking top-down, and we're thinking with this broader framework, things such as the characteristic and narratives of the larger society, the societal systems and structures, the neighborhood, and the home and peers are all things that we have to take into consideration. And whether we are seeing someone in a neighborhood that is different than ours, perhaps in the same city, but certainly when we are seeing people in another part of the country or trying to teach or understand their circumstances, these are all important things for us to consider, not just our understanding of the individual in front of us based on what the DSM says they have. So defining social justice. This is one definition from John Rawls, which is assuring the protection of equal access to liberties, rights, and opportunities, as well as taking care of the least advantaged members of society. And here's one by David Miller, the distribution of good advantages and bad disadvantages in society, and more specifically, how these things should be distributed in society. It is concerned with the ways that resources are allocated to people by social institutions. And so some principles of social injustice that I wanted to go through quickly, and the reason I'm sticking here for a bit is that what we see when we look around, right, is that there is a lot of injustice. And when we're considering these adverse social determinants of health, there are ways that these things show up, that they end up shaping who gets access to opportunities and resources, and that they also can end up undermining those bedrocks of mental health. So essentialism. The belief that there are distinct, unchanging, and natural characteristics that define social groups, and facilitate their categorization. So an example you're likely familiar with when it comes to this is the well-intentioned cultural competence seminars that say Black people do this, Latinx people do this, immigrants do this, right? They paint very broad, very diverse groups of people in these very flat terms. Erasure of context, failure to consider socio-historical context when seeking to understand the ideology of inequities. Biological determinism, the false belief that racial groups are biologically and genetically different, and cultural determinism, which is something we have to guard against when we are in other places in the world, is the false belief that differences in ethnic groups are the result of cultural factors. And so I welcome you to think about these forms of oppression and how these forms of oppression could make it hard for someone to attain that ideal of mental health, and to also consider how you go into a dynamic, or how you go into a clinic, or how you go into a community, and think about how these are playing out and how people are thinking, feeling, behaving, and how they're interacting with you. So things such as exploitation, the unequal exchange of one group's labor and energies for another's advantage and advancement. We see this sometimes when people go and do research in communities or on communities, but then are not serving that community. Cultural imperialism, when the ruling class culture is established as the norm. And an example I like to use of this is that in these cultural competency seminars, I have never seen one on white culture. Have y'all? No hands are up for the people that are streaming. Powerlessness, when oppressed groups lack power and are blocked from to gaining power. Marginalization, when people do not have meaningful participation in society. And violence. And so I know that this crowd knows what health disparities are, right? And I'm doing this as a setup. But with health disparities, you are acknowledging that there are differences across people in health outcomes. But what I'm really getting to, right, is health inequities. Because there are many times when we frame things as disparities that are actually inequities if we look harder, because there is some systemic, avoidable, and unjust social and economic policy and practice that is creating barriers to opportunities that is the ideology of those differences that you see. And it's important. It's an important distinction, because if it's just a disparity, you can say, oh, golly gee, isn't that difference interesting? Whereas if it's an inequity, it can point you to actual solutions that help you realize a different outcome. So I promised you some stats. Here they go. So the World Health Organization released a report a couple of years ago, and these are some numbers that I thought tell a pretty compelling story for why we need to be talking about mental health and centering it. 1 in 100 deaths worldwide are due to suicide. When we look at people with schizophrenia, they died 10 to 20 years earlier on average, not from suicide, but from preventable medical conditions that they didn't have treated. And when we look at mental health expenditure in middle-income countries, over 70% of it is going towards psychiatric hospitals, rather than being in the communities and where people are. And around half of the world's population lives in countries where there is just one psychiatrist to serve 200,000 or more people. So we have to rethink what the workforce looks like. We have to rethink how we apply this work if we're going to be impactful. The World Mental Health Report, Transforming Mental Health Care for All, identified 3 priorities in its conclusion. One was that there needed to be a strengthening of mental health care, where there's a full spectrum of mental health needs met through a community-based network, so not hospital-based, community-based, that is affordable and with quality services and support. Thinking about those social determinants of health and those structures that frame those social determinants, they spoke about reshaping the physical, social, and economic characteristics of environments. I really do feel, especially as a child psychiatrist, that often I'm doing tertiary care, right? Things have been bad for a long time by the time they get to me and we're trying to put things together. I get to do very little health promotion. That health promotion has to happen at that systems level and more upstream. And then deepening value and commitment. And that speaks to the commitment we give to mental health as individuals, communities, and government, and across all sectors. And so some lessons learned. I mentioned I was asked to give a keynote in Amsterdam, and it was a very interesting experience because I had dinner with the planning committee and the essentially like the Amsterdam Psychiatric Association e-board the night before. And I'm sitting in this room, and I'm the only person of color as far as I can tell, and everybody's telling me how egalitarian their society is, right? And then I meet this psychiatrist on LinkedIn who works there, and he's the one who connected me with the other psychiatrist I mentioned earlier. And it highlighted for me that even in places where people have egalitarian values, right, where they may be doing relatively well, there are ways for these things to creep in, even among those who are well-intentioned. So when it comes to this work, when it comes to the spaces that we're in, it's something for all of us to guard against. I taught in Liberia teaching PAs, midwives, and nurses for a period of like 2.5 years, and I would go every 6 months. It was shortly after Ebola had ended. And it was a really interesting experience because I was teaching about adolescent substance use. And the substances that the kids at Metro RYDC in Southeast Atlanta use are different than the ones in Liberia use. And what I also found is that every 6 months, those substances changed, right? So as the society became more stable, more substances started to infiltrate. And so I had to spend my first day of teaching listening. They had to tell me what they were seeing. They had to tell me what substances were relevant. They had to tell me what treatments were even available. And then I had to go back that night and create my lesson plan based on that feedback I received from them. I'll also say it was a lesson in not taking things for granted and of having a realization about some of the privilege that I've had growing up here. And all of these exchanges are always bidirectional, and I always feel as if I learn more, but I was there during the inauguration of President Trump, and they kept trying to show it to me on TV, and I was like, I'm good, I don't think I need to see that. But they've placed so much value on the peaceful transition of power, no matter who it was, whether you voted for them or not. And it reminded me of something that I had taken for granted in terms of living in this country. And in the Bahamas, this wasn't supposed to be a work trip, but I ended up connecting with a psychiatrist there. And his name is Dr. David Allen, and he's from the Bahamas, trained at Harvard, came back. And he has this group called The Family. And there aren't that many psychiatrists in the Bahamas, certainly not that many that are seeing people who don't have the means to pay out of pocket. And I had the opportunity to sit in on Dr. Allen's group. And the beautiful thing about it was that it was one of the most diverse rooms I've ever been in, racially, ethnically, socioeconomically. But he saw it as a way to extend his services to a broader group of people. And on an island where people can sometimes feel isolated because there's so many different things coming together, it brings community. And not only did he have the group at the church that was kind of like the formal meeting, but something really interesting happened. He invited me to lunch at his house afterwards, and people from the group start showing up at his house. It was so alien to like what we would expect in the United States, but you could see that this was truly therapeutic, also truly a community, but also he wasn't bound by these demarcations that we have between patient and physician here. And so I always want to talk about the burden of resilience, right? Resilience is important. I'm not anti-resilience. It is critical. But we always should ask, who do we ask to be resilient and why? Where is the emphasis on prevention and protection? And if it's not part of the conversation, why not? Because what I find sometimes is that people in positions of privilege like to focus on people who are not privileged being more resilient, rather than focusing on how do we contribute to the circumstances that lead to the traumas that they have to be resilient in response to. And those are questions that we always want to ask. And so your obligation as a healthcare professional or as a leader, we all have our own versions of our superhero capes, right? But I ask all of us, and I'm constantly asking myself and the trainees in our department to reimagine our roles. Is our role the provision of clinical care or the promotion of the population's mental health? Is it the elevation of expertise defined by academic credentials or the elevation of lived experience and local expertise? And is this problem one that's owned by mental health clinicians or one for all healthcare professionals and societal leaders? And when we think about those statistics, 1 in 100 worldwide, half the population living in places with one psychiatrist per 200,000 people, Is this a situation that calls for incremental change or one that is commensurate with the situation's urgency? And so moving from treatment to the actual promotion of health, right? We talk about lifestyle medicine when it comes to diabetes and heart disease and all of these things. It applies to mental health too, y'all. And the great thing about it is even if the country is out of Prozac, which happens sometimes in some of these places, right? These other things can be implemented. James Baldwin says, ignorance allied with power is the most ferocious enemy justice can have. I imagine that sometimes you don't feel as if you have all the power that you would like to have, but I promise that by virtue of you being in this room, you have some power that you can leverage. And so the World Health Organization talks about having power over, being able to influence and coerce, power to, being able to change existing hierarchies, power with, the collective powers of communities or organizations, and power within our own individual capacity. And some ways that this could look for us, right, are as advocates and people who can influence, as administrators, as educators, and as clinicians. And so just wanted to share a little bit about my team. So I'm here, I'm the chair of the department, but there's a team behind me always, and these are our folks. Anybody you see with an asterisk did some part of their training at Morehouse School of Medicine, whether that was a medical school, residency, or fellowship, and you'll see a number of asterisks as we go through. But these are our child psychiatry faculty, these are our child psych therapists, these are our adult psychiatrists who are at Grady doing integrated care, and these are our folks doing acute services and at Student Health and Wellness Center, and these are our CL and addiction faculty. One of the things the World Health Organization talked about was having a broader continuum of services, and traditionally in our department we've done strictly adult outpatient. We've done some community work in like a DJJ facility, but one of the things that I wanted to do was diversify the kinds of sites where we were working, and we've been able to do that and recruit some amazing people. So Dr. Elania Morgan James, she'll be the inaugural medical director of the Fulton County Crisis Unit, which is going to be the first acute service that is staffed and directed by a member of our department. In January, we welcomed Dr. Nicole Jackson, who is a forensic social worker who will be doing re-entry services with people who have been identified by the Fulton County DA's office. And on deck, in final stages, is a contract with the U.S. Virgin Islands for us to provide child psychiatry and forensic psychiatric services there. I'm a psychiatrist, so I have to plug self-care, right? Because doing this work requires a lot of you. And so Audre Lorde says, caring for myself is not self-indulgence, it is self-preservation, and that is an act of political warfare. And I'll end with a question, which is how can every person adaptively cope with the stresses of life, realize their abilities, learn well and work well, and contribute to their community in a world that fails to assure equal access to liberties, rights, opportunities, and chooses not to care for its most vulnerable members? And if you are paying attention, you get the gold star. That's the definition of mental health and the definition of social justice. And I would argue that in an unjust world, in an unjust society, mental health on a population level cannot exist. And with that, I thank you for your attention. The boss is telling me to stay just a minute.
I think we have time for a few questions from the audience, if you'd like. In our way of I'm an infectious disease physician. My wife is a psychiatrist, but as we've gone into this global health equity business, it's clear to me that women's health and mental health are really at the root of almost all the inequities. So I think we should spend some time asking questions.
Well, good morning, Dr. Benson. This was fantastic. I really enjoyed it. And one of our pillars of lifestyle medicine in public health and preventive medicine is, in fact, I am speaking. This is better? All right. I'm Sonia Hutchins, and I'm the director of the Public Health Preventive Medicine Residency Program at Morehouse School of Medicine. And I really enjoyed this wonderful presentation by my colleague, Dr. Benson. And I wanted to ask you, based on Secretary Becerra's discussion when he came at convocation on Friday of last week about the partnership with the increased partnership with behavioral health in 100 historically Black colleges and universities. I know we talked about training, and when you see the small, I guess the percentage of psychiatrists that we need, which is a huge amount in this country, to care for the mental health and emotional well-being of all of us, it's important to understand. So I was wondering whether you'd heard about that partnership and what some of your thinking is about that and how we all can help.
Yes, so I'm a huge believer and a product, frankly, of pipeline programs. I grew up in rural Northwest Florida and never saw a Black physician until I went to a HRSA-sponsored program at the University of Florida College of Medicine. And after seeing that Black doctor, I went back home and said, I want to be a doctor, right? It's a real thing. And so representation on those campuses is critical. And I think that we also have to yes, we need Black psychiatrists, but we need Black mental health workers, right? And as a mental health field, we are so behind in terms of what the workforce looks like. We have to think more broadly. We have to be more inclusive. And medicine can be quite territorial and guild-like at times. And so, again, really rethinking how we define expertise and who's at the table. As a rule, right, a job that requires you to delay your first job, a profession that requires you to delay your first job until your mid-20s is not accessible to everybody, right? So when we think about having a representative workforce, routes to being part of that workforce that don't come with as many barriers are going to be more representative of the community. And the example I'll use is when we have peer specialists as part of the team, right? They're not only more representative because they have the lived experience of having mental health conditions, but usually they're more likely to be from the same socioeconomic class. They're more likely to be people who represent the community in other ways as well. And so I'm excited about those programs, and I think that as physicians, we also have to be part of the chorus of helping people understand there's room for a lot of different kinds of expertise at the table and different routes to getting to the table.
Could you explain to me the pig in the water and mental health in the Bahamas?
Oh, sorry. So one of the things that the Bahamas is known for is their swimming pigs. So it's like a Bahamas picture. That's all it was.
So the way the American healthcare system works is really focused on individuals, not communities. But the way healthcare has to work internationally, especially mental health care, has to be community-centered coming back. And so my question is, and when we think of global health equity, we don't want to take the American healthcare system and put it someplace else, because most of us, I think in this room at least, realize how broken it is. The question is, how do you bring the community-centered focus on healthcare and mental health care back into the U.S. system?
That is a great, great question. I think it's going to take a critical mass of physicians and people who are in the room, right, to raise this issue up. And I can tell you they're not used to physicians saying, where's the social worker? Are we talking about schools, right? They expect you to come in and talk about diagnoses and medications, and here's my clinic. But we do have a voice. The people in this room, you have some sort of platform, right? Some sort of reach. You have a voice that can help people start to understand, because I think that the individualistic framing in our healthcare system, we can see parallels in it in terms of how we think about society, right? Like we have this very individualistic, pull yourself up by your bootstraps, like American narrative that I think permeates the healthcare culture as well. And so it's going to take some really intentional pushback and reframing and narrative shifting for people to understand, but I do think that it can happen if enough of us are sending that message.
Thank you very much, Dr. Vincent. Okay, our next speaker is Stacy Kinke. She is the CEO of Medshare. It's another example of how community sharing will be a route toward better global health equity. Thank you.
Thank you. Good afternoon, or still morning, I guess. Thank you so much for having me speak here today, and thank you so much for the invitation. Like one or two others, I want to state just up front, I'm not a physician. I don't have a doctor in front of my name, a PhD behind it. I am a CEO of a nonprofit, and I'm just thrilled to be here to be able to talk about the work that we do. So as I was thinking about what am I going to speak to you about today, I had to really think what would be interesting, what is something that you would care about or want to know. So at the very least, I want to make sure for those of you who don't know, you have an opportunity to hear a little bit about what the organization that I work for does, what is Medshare International. And second, I want to talk about how we have been able to use the power of partnership to impact healthcare around the world, and increasingly here in the US. Last year in 2023, Medshare celebrated its 25th year as a healthcare nonprofit. And it is my privilege to have been able to come aboard in this last several months to help to lead Medshare into the next 25 years of service. I was originally, previously in another nonprofit, and before that, most of my career was in for-profit. But I've committed myself for the remainder of my career to be in this nonprofit space, and today in the healthcare space. So what is Medshare? In a nutshell, Medshare's mission is to support medical missions and charitable clinics and hospitals around the world by redirecting surplus medical supplies and biomedical equipment to healthcare organizations in underserved communities. As you know, there is a lot of waste in the medical community and in healthcare settings, and we are part of the organizations, both here in the US and around the world, helping to ensure that that waste doesn't go to true waste. We're actually able to utilize it where it's needed most. So how do we do that? We partner with hospitals, with medical practices, with manufacturers, and with individuals in the public to source needed products and then work with NGOs, ministries of health, and other nonprofits to get these items shipped to where they are requested. And I want to emphasize requested. So many organizations push materials out into international countries, not really asking what is needed, not really making sure that what gets sent is what is necessary, what is required for that organization, that community. One of the things that we make sure that we do is actually enable organizations to order as if we're Amazon, not quite that big, but as if we're online ordering, so they can actually look for exactly what needles and syringes, what medical beds, what wound care is specifically needed for the facility that they're supporting. I also want to emphasize that we work to prevent adding to medical wasteland by making sure that we don't allow expired or unusable materials to be shipped. And we are one of several organizations in the US that are accredited medical surplus and recovery organization. Our programs focus on primary care, maternal and child health, and disaster relief and response. One unique element that I feel that Medshare has is that we also work to provide training on troubleshooting and repair of equipment that has been donated and shipped, so that equipment that is donated can have a lasting and a sustainable impact, and not just a one-time and then ends up being pushed aside into storage. often when we send our resources over to help do the training, one of the first things they have to do is go into the back room and pull out equipment that had been sent by other organizations that have fallen into disrepair that couldn't be used because no one knew how to reprogram. No one knew how to troubleshoot. No one knew how to repair. And so that's one of the unique things that Medshare makes sure that we do. So to date, Medshare has completed over 2,200 international container shipments to over 110 countries. We've donated supplies and medical equipment worth over $325 million. We've trained over 1,700 biomedical technicians and end users and impacted the lives of over 33 million patients in our 25 years in service. Medshare is a relatively small organization, staffed between 18 to 40 at its peak. So we know that we can't do this alone. We believe that it's through the power of partnerships that what we've done can be achieved and can continue to be achieved. And so I want to talk about a set of partnerships that have allowed Medshare to make a significant impact around the world. And first, I want to start to talk about our impact in Ukraine. Ukraine was not our typical disaster response. We've had support in Haiti, and earthquakes in Syria, but supporting the disaster in Ukraine was very different. As we know, for over 2 years, the war in Ukraine has taken the lives of thousands of civilians. Additionally, the fighting has injured tens of thousands more, with devastating injuries to limbs and spines. Our initial response to this disaster occurred just 1 month after the initial invasion began, finding on-the-ground NGO partners to ensure that needed medical supplies would reach the civilian population. Some critical partners have included a variety of medical manufacturing partners to provide PPE, surgical supplies, and unfortunately, post-mortem kits. We also work with the local Amazon warehouse to provide key supplies such as wound care, casting material, splints, and crutches. We work with a freight partner, Airlink, to provide deliveries to Poland, who had land freight then to get material across the border. We've had a multi-year partnership with DuPuis Synthes of Johnson & Johnson, providing surgical screw and plate sets to physicians doing periodic medical missions. And through this, we were able to expand that partnership. It grew to be able to provide over 350 surgical sets to surgeons caring for a wounded population. In total, we worked with 14 on-the-ground partners, including one major partner, Razam for Ukraine, to whom we have delivered 11 separate air freight shipments. All of these partnerships have allowed us to deliver over $30 million worth of healthcare equipment and supplies to Ukraine and impact countless lives. We also have a decade-long partnership with the Nigeria and Cote d'Ivoire business units of the Coca-Cola Company to support their maternal health care in over 6 hospitals. We started with pre-assessments in those hospitals where we sent our resources to go and see what was actually needed. Again, our commitment to ensuring that we aren't sending things that aren't necessary or that will end up in a wasteland. To date, we've been able to source and provide incubators, baby warmers, infant monitors, birthing beds, exam tables, anesthesia machines, ultrasounds, along with countless other necessary PPE and surgical supplies. But not only do we provide the equipment, as I said earlier, an additional critical element of this partnership was to deliver hands-on training for each hospital's biomedical staff. It's typically a 2 to 3 week process, and we leave behind both repair kits and spare parts for all the equipment that we source, transformers for all the equipment, along with the knowledge and skill to use everything that we've sent. In this project alone, we've been able to impact over 700,000 patient lives, with the equivalent of over 3 million in medical necessities delivered. Although this international project in our maternal and child care program is winding down, today we are increasingly focusing our efforts within the U.S. to address more underserved communities lacking basic healthcare services. Having survived the peak COVID years, and honestly, it wasn't guaranteed that we would, it became clearer that what may have once been considered to be primarily an international issue continues to be a challenge here in the U.S. We, of course, know that Georgia ranks poorly in maternal health outcomes, and the maternal and overall health outcomes for the U.S. is significantly below its peer economy nations. Today, Medshare is growing our partnerships with the Georgia Charitable Care Network and the National Association of Free and Charitable Clinics. And just as a side note, the National Association of Free and Charitable Clinics has a conference this coming weekend, which we'll be participating in here in Atlanta. Although we've always supported a small cohort of charitable clinics, such as Ethne Health Clinics in North Decatur, over the past year, we have tripled the number of clinics that we serve, both here in Georgia and across the U.S. With these charitable care associations, along with a partnership with BD, we will be delivering portable ultrasounds to over 80 clinics, along with training for both maternal and cardiac care. We have seen how the power of partnerships can multiply and make a major difference in helping to meet healthcare challenges around the globe. One person, one organization cannot do it alone. But I'm encouraged that we'll be continuing to build coalitions and partnerships to help healthcare organizations supporting underserved communities, wherever they are around the globe, to thrive continuously. I encourage the people in this room to join us, and I thank you for your time today.
Thank you very much. I'm not going to let you leave yet because I think we have some questions for you. And we don't get very hung up about the letters behind somebody's name. Morehouse had a convocation ceremony on Friday where over 300 new students were welcomed into the Morehouse School of Medicine family. And only a little over 100 of those were medical students. So there's 14 degree programs that cover everything from medical cannabis to administrative to physician assistants, masters in public health, biomedical sciences. And so the letters don't really matter. And I think we can see how big a role everyone needs to play in creating better health equity. So my question is, after spending 21 years in government at NIH, knowing how privileged we were to have updated modern equipment or repaired equipment, and also knowing and seeing huge warehouses of old equipment or discarded equipment, some of which was not that old. You're providing equipment to medical groups. Do you also have a system to provide scientific equipment so that we can build the scientific capabilities internationally?
So the primary equipment that we provide is biomedical. We do have some scientific equipment, but most of the facilities that we serve are not equipped to, are not research facilities. They're not equipped to, those aren't the primary equipment that they're asking for. They're really looking for equipment that enables them to treat patients better, to make sure that they're able to diagnose and to prevent disease and prevent mortality in their countries. So we do have some. We do work, depends on the hospitals or manufacturers that we are able to partner with, but that is a secondary part of what we do.
Anybody else have a question? Dr. Floyd.
Help us understand how would they register with you? How could they partner with you? What can I put in the suitcase and take with me?
Well, great question. We're actually located in Decatur, and so we have a way for you to actually just come on site and identify material that you'd like to bring in a suitcase with you. What we ask, you can sign up online. We've built out our online application process. Everyone who is a physician is able to apply online, let us know where you're going. We'd like to give you an opportunity to apply at least 3 to 4 weeks in advance of your trip to make sure that we have the material that you might be looking for available in our warehouse in this online store. If there's a more extensive items that you're looking for that may not be on our on-site store because it's much smaller. We actually encourage people to apply and to do online ordering. We have built out the opportunity to see our entire inventory online, and you can order as if again, I mentioned we're not quite Amazon, but the number of items that we have in stock are very extensive. You can place that order. You can then pick it up at the facility in Decatur or have it delivered to you, and then you can take that on your medical mission trip. We do have a biomedical engineer on staff. If there are questions about particular items that we have, or you're specifically looking for particular items, that we can have discussions with you about what we may or may not have, or what may be useful substitutions for what you're looking for. So we do encourage you to take a look at medshare.org, sign up with an application, and we'll be happy to be able to help you fulfill a medical mission.
Thank you very much. So we're going to break for lunch. We'll be back promptly at 1 o'clock. Dr. Virginia Floyd, we call her Ginger, will be moderating the rest of the sessions for the afternoon. And we'll review the Global Health Equity Institute program at Morehouse School of Medicine just after lunch. So see you then.
to this code to encourage you to participate, and we hope to have time for question and answers, if our speakers will stay on time, okay? We want all of you to engage in today's dialogue. We want you to leave better informed and committed to helping the MSM David Satcher Global Health Equity achieve its goals. So throughout the morning, we have shared a brief glimpse of the work of the David Satcher Global Health Institute. You have met some of our global health partners who are working with us at MSM to achieve global health equity and justice. A tiny look into the scope and reach of our global work. Now, I would like to invite the leadership of the David Satcher Global Health Equity Institute to come and to share with all of us the journey, the history, projects, and the dreams of the Institute. Dr. Barney Graham joined MSM family as the director of the David Satcher Global Health Equity Institute, and he also is a professor in the departments of medicine and microbiology, biochemistry, and immunology. Dr. Graham was recently named one of the world's most influential individuals by Time magazine. Many of us recognize him as the former deputy director of NIH Vaccine Research Center and the leader of the team that helped discover the vaccines for RSV and COVID. We are very proud of Dr. Graham. Our deputy director, Dr. Gilberty Bastien, Gigi, to those of us who know her, is a clinical psychologist and has shepherded the growth of the Global Health Institute over multiple years at MSM. Gigi's journey began in the earthquake and hurricane disasters of Haiti, and it later took her to the Ebola epidemic of Liberia and Sierra Leone, where, as a Fogarty Fellow, she worked with families suffering from Ebola. While most of the world was running away from nations with Ebola, she ran to them. Her research focuses on the intersection of global mental health and culture. Dr. Bastien is an assistant professor in the Department of Community Health and Preventive Medicine. The two will now join me on stage, and they will share the evolving vision of the David Satcher Global Health Institute. Dr. Bastien will speak first, and she will be followed by Dr. Graham.
Merci. Good afternoon. Back again. Great to see new faces have joined us. Please signal me if this thing travels away and you can't hear me. I have been accused of being soft-spoken many a time in my lifetime. I will try not to let that be a barrier to our conversation this afternoon. So it's a pleasure to share with you, as Ginger outlined, a bit of the work, the history, and the vision for moving forward with Morehouse School of Medicine's Global Health Equity mission. And we talk a lot and often as a team about how this for us is very much a global mission, a mission that takes and draws from the history, the track record of the amazing equity work that Morehouse has led since its founding as an institution, and to sit and consider with our partners around the world how that base of experience and expertise can be leveraged for global impact. And so when we talk about that connection between the global and local that you heard Dr. Glass reference this morning, that is core to our ethos as a unit, and you'll hear that echoed in our conversations. So we will begin with a little bit of kind of the impetus for the formalizing of an agenda around global health equity at Morehouse School of Medicine. So we are situated here in Atlanta, which happens to be one of these hubs for global health. We find here in Atlanta the CDC, the Medshare, Task Force for Global Health, a number of institutions who are doing work in global health. And so we really did sit as a team and consider what is it that we see in this area that creates an open lane for us? Why should we really step more fully into this space? And what came out of those conversations was the identification of what we saw as some critical gaps in how global health work was being carried out in so many parts of the world, right? We saw really a lack of acknowledgement of where the inequities we were talking about were coming from, right? So for folks who are familiar with Kamara Jones, to the reality that our colleagues from Partners in Health talked about, that Paul Farmer would speak to the problem of seeing certain lives as being valued as less than others, right? That it was important that we name those things that are leading to the problematic inequities that we see in global health. We also saw that there was not nearly enough acknowledgement of the integral role of culture in shaping health, in informing how we bring about health solutions and public health solutions in our communities. And finally, we saw the repetition of a pattern that we have been working hard to overcome even here in the US, which is the tendency to move and operate in silos and not enough of the bringing together of effective and functioning coalitions. I alluded to earlier the fact that our challenges are far too complex in this space to have the luxury of being able to go at this alone. We absolutely need to bring forth expertise and to ensure that it's the right partnerships, right? Folks with aligned vision, folks who understand and know the communities that we seek to serve. And so we saw these as critical gaps that Morehouse School of Medicine was uniquely positioned to respond to in this arena of global health. And we felt confident about that for a number of reasons. The fact that we are a historically Black institution with cultural ties and connections to a lot of the parts of the world that we were interested in doing work at. The fact that our mission is strongly embedded in a social agenda, a social mission for the world. The fact that sitting with communities as substantive partners has been a part of our very DNA as an institution from its inception, we thought equipped us to be able to carry that into the work that we're doing internationally pretty seamlessly and organically. It's already the way we work. Central to our work has been this issue of workforce, and we knew we were hearing in all of our conversations with global partners, workforce shortages, workforce challenges, and this is at the heart of what we do. We train future leaders in global health, and so we thought that could be an important contribution. Our emphasis on primary care as a really central and core piece of a functioning and healthy society and population we thought was also a strength. The fact that understanding that how we work, how we live, these social determinants are a critical piece of the analysis of what health and health intervention should be about are things that come natural to us and a part of the conversations we're constantly having at Morehouse School of Medicine. And we thought that positioned us to be able to bridge this local wealth of expertise and experience to meet the unique and current needs of our global community, and that positioned us to really lead a powerful mission for change in the world. And so this emboldened us to step into this arena, and we marked that decision with an inaugural Global Health Equity Symposium, which happened in 2018. We were joined at that time by 3 of the then NIH center directors, including Dr. Roger Glass, who was honored this morning, Dr. Anthony Fauci, and Dr. Gary Gibbons, who was also formerly faculty at Morehouse School of Medicine. We were thrilled to have him come back to see how we were taking all of the good that he knows of who we are as an institution and really thinking substantively about how that could benefit a broader world and community. We had Ambassador Andrew Young and a number of other partners from around the world with us in celebrating the launching of Morehouse's more formal role in this space. It takes a village to move this world, so I wanted to share a little bit about the small but mighty army of folks who are part of our global health team and work group. And what I think is important to emphasize here is one of our important values in terms of having a unit that functions with the horizontal sort of focus, right? It was important to us that we would not be isolated and set aside in what we did, but that we were being intentional about bringing around the table people who represent different departments, different centers, different institutes to really help richen the conversations and the types of perspectives we would be drawing from to inform our work. And so we're thrilled to have that diversity reflected in our team. And an important extension of that team includes our students, our learners at Morehouse School of Medicine. So you see pictured here some of the members, the original members of our student global health interest group, a really impressive number of young folks who literally knocked down our doors and would not stop emailing until we made room around the table to sit with them and hear about their dreams, their passions, what they wanted to see in global health. And I am excited to report that several of them have gone on to do some really amazing things. You will later this afternoon get to hear from Melissa Isabube, who's in the middle there with the Morehouse t-shirt. She is currently spending a year as a Fogarty Global Health Fellow in Malawi. So she was due to join us virtually. We may not be able to do it that way, but she put together a video so that you'll get to hear her voice and what experiences she's having so far during her year in Malawi. And immediately to her right for you, Jenny, the co-founder of the student group, is, as we speak, in India, completing a 4-week elective on Siddha medicine, where they're learning about ancient medicinal practices. And so you see pictured there a group of our students who traveled to Costa Rica this past summer. They spent 10 days in Costa Rica, hosted by the University for Peace, for a first-of-its-kind interprofessional group of students engaged in a global health immersion experience. And this is something we've talked about often as a team, and it was exciting for us to finally see it materialize in terms of what can happen when you have the cross-pollination of bringing together our public health students, our JEB students, graduate students in biomedical education, our medical students, a couple of our residents were able to join us, and to bring them together around shared challenges and shared opportunities in global health. You'll get to hear more directly from some of the students and learners who participated in this afternoon, but these are the kinds of opportunities we're seeking to grow for our learners at Morehouse School of Medicine, the opportunity to take the best of what we have across our programs and to partner with communities to think through solutions. You also see pictured there Dr. Jonathan Stiles, who has been really a leader in investing in one of the spaces where we spent a lot of our time globally in terms of Ghana in building capacity bidirectionally, right? And helping our students to learn what it is to conduct effective, rigorous scientific research in a context like Ghana, while also learning from and benefiting from the expertise on the other side. And so you see the engagement of partnerships that is such a critical part of creating those opportunities for our students and faculty. For those who were here with us this morning, you heard quite a bit about the Fogarty Global Health Fellowship Program, which I got to be a fellow myself as a postdoc. We've had a long-standing relationship with Fogarty that has really helped us to equip our students to be able to contribute not only in the area of public health and clinical interventions, but importantly, research, right? Understanding that there are critical gaps in the knowledge base that informs what we do, and we want to not be repeating the patterns that we've seen of people exporting directly things that we could debate around the effectiveness of even here in the States how some of these models and interventions work, and oftentimes we're seeing folks export those models without examination, without question in other settings. And so we want our learners to have a role in developing the homegrown knowledge base that gets to inform and drive intervention in the settings in which we move. So again, you see Melissa Isabube, who is spending the year in Malawi. You also see pictured there several of the Fogarty Fellows completing a 1-week orientation that happens annually. Dr. Kofi Kandwani is pictured there, who, along with Jonathan Stiles, Dr. Jonathan Stiles leads this fellowship for Morehouse. And so they're part of a consortium along with Johns Hopkins, UNC Chapel Hill, as well as Tulane University. They share some of the work that happens as a part of this training program. Our focus has always been around capacity in the sense that we want to ensure that when we sit with community and we create and think through solutions, that those solutions don't end with our physical presence in country. So what happens with those communities after we are there, right? And so, I want to share one example of what this looks like for us at Morehouse School of Medicine. Again, returning to Ghana, which is one of the international sites where we've invested quite a bit as an institution. So oftentimes the dynamic that we see with academic and global collaborations is that the US-based institutions will secure grant funding, often with us as the lead institution, the lead entity, and we're sometimes are bringing on international partners as subs to accompany and support the work that we're doing. But often they're brought along further down the road in that work, right? And so what we started to think to ourselves as our relationship and history of collaborating with the University of Ghana and other partners in country evolved was that there's more than enough here for our partners in country to be driving and leading and producing their own solutions to the challenges we're thinking through about them. So how do we help ensure that they can do that and be competitive in putting forth bids for funding to really lead and support some of the work they're wanting to do? And so we brought a team of folks from our grants office, from our finance team, and had them sit with their counterpart on the Ghana side to learn about how do we ensure we have the infrastructure in place so that we can manage the grant funds when they're here, so that we're able to keep up with the reporting. And ultimately, we got to a place where our partners in Ghana were leading their grants and bringing us on as subs. That, for us, is the model of what substantive collaboration and building capacity should look like as we move in global health. Emergency preparedness and response has been an important area of focus for some of our work. That began, as Dr. Floyd mentioned, for me personally, with work in Haiti around the earthquakes and too many subsequent disasters, as you heard our colleagues from Partners in Health speak to this morning. That work then extended to Liberia and Sierra Leone. And what has been a critical through line and common thread in that work has been understanding the value of the expertise and the assets that we find in those settings when we get there. Even in the midst of disasters and crisis, asking ourselves not just what is wrong in community, but what is strong, and how do we leverage that, and how do we accompany communities in a way that further empowers continued impact. And so both in Haiti and Sierra Leone and Liberia, our work was focused heavily on community, right? Training community health workers. You see the gentleman there in white t-shirts seated. These are traditional healers and faith leaders in Liberia who ended up being really the key ambassadors and spokespeople who drove the health behavior change that needed to have to stem the spread of Ebola in Liberia. For a lot of folks, they didn't fully understand why they shouldn't convene and come together and meet in the imam and their usual places of coming together until it was from their trusted community leaders that message was coming, that we started to see the behavior changes that needed to happen. And so we believe that's a critical piece of how we move, understanding that we may have the right information and message, but we're not always the best messenger. And so how do we empower and create space for those trusted voices where we move? I've spoke to the importance of community partnership, but critically that's also part of research and how we do the health intervention and clinical health research that happens around the world. You see a picture there at the top right for you in Sierra Leone, where I am working with one of the community research assistants around cultural adaptation of one of our questionnaires to ensure that it would be culturally and linguistically appropriate for that setting. You know, you've heard the theme. We're going to be sort of like a broken record around certain things, and collaboration and the importance of working as a team in global health is one of those themes that we hope stays with you as you move away from this summit. But what we have learned over the past few years is that when we pull together the expertise, the information, the connections that we have with other institutions, we really can see an impact magnifier like no other. And a great example of that has been our work as a part of the HBCU Global Health and Development Consortium. It is a consortium made up of the 4 HBCUs with medical schools. I'm excited to know that we now have a 5th HBCU coming on board, which happens to be my alma mater, Xavier University. But when we moved into this partnership, it was these 4 institutions, Meharry, Morehouse, Tuskegee, and Drew out in California. And so what we decided to do was to come together, drawing from the best of what our institutions do, and to sit with partners in Zambia around developing solutions for HIV/AIDS care in country. And so just a bit earlier, you saw what our sort of global footprint and reach was, but here we see that magnified when we come together with our sister organizations. And so what this team has been doing, they are now in their 2nd round of PEPFAR funding, a 5-year PEPFAR funding. Specifically, it's the National Center for Primary Care at Morehouse School of Medicine that has been implementing this PEPFAR-funded work in Zambia to really improve HIV/AIDS service. with a key focus on prevention and treatment for some special populations, and attention to reducing the stigma and discrimination that can be so problematic, as well as the economic impact, right, for families and individuals affected by HIV. And we're excited that that work has done really, really well and is now expanding to a replication of that model in Malawi, which is a testament to what we can do when we come together. We've talked about this notion of a global mission, of bridging the local to global, and one of the ways we're helping our students and our faculty to really think about that is this idea that when we say global, it does not necessarily mean some faraway place. We don't have to get on a plane to touch the globe. Here in the city of Atlanta, the globe in the world is here. Here in this room, the globe in the world is here. So what we've been working to do is to help shape this sensitivity in our students of understanding that immigrant and refugee communities, as one example, give us a real window into the world as it is here, and how cultivating global perspectives can actually help enhance the work that we do here at home. And so we've been working to grow opportunities to support our immigrant and refugee communities in health. In particular, I'll lead, along with Dr. Alitha Lozana, who directs our innovation learning lab here at Morehouse School of Medicine. We've been leading some work to train Haitian American young adults between 18 and 24 years old to serve as community mental health workers, right? So you heard from Dr. Vincent this morning how we are not going to specialty train our way out of this mental health crisis that is knocking on the door of every nation around the world right now. We're not going to quickly train up enough psychiatrists, psychologists, social workers, et cetera. We need to draw from the base of talent and potential in communities and equip those partners to really do substantive work with us. And we've seen it bear out that we can do great work and have significant impact when we train community members to be a part of that work, of basic education around mental health work, of helping to make people aware of resources they did not know exist, helping to just create room for having conversations that are often taboo and giving people permission. So we are excited to be engaging our young folks. This work is currently being implemented in Atlanta, Miami, Boston, and New York with a focus on the Haitian diaspora communities in those sites. You see an example there, one of the recruitment flyers. But these students go through a 6-month program with us, an online curriculum that then prepares them for developing, implementing, evaluating community interventions. And so you see pictured there on the right one of the health fairs that our group in New York put together recently to share information with community members. Our partners here in Atlanta, the young folks were able to earlier this year put together a women's self-care. So these young folks were having conversations about why it is that their mothers do not have any concept of self-care and work tirelessly, and they thought it would be a great contribution to community to have a weekend dedicated to carving out space for women like their mothers in that generation. And so we partnered with a local church, and they were able to do what has now become an annual event. The church has committed to maintaining that program because of the impact that it had and how well received it was by their communities. And so we're learning that you provide a little bit of training and get out of the way and watch community do beautiful things. And we think that's an important model for us in global health. As we strengthen the work and our engagement of immigrant and refugee communities, we've started to strengthen our conversations and collaborations with partners, including in places like Clarkston, which is actually considered the most diverse square mile in the entire United States, stone's throw away. The world is literally here. This is a town with people from over 60 countries speaking over 40 languages. And Ginger, Dr. Floyd, and myself have the honor of accompanying a group of our first-year medical students for their first-year community health course every Wednesday afternoon out to the Center for Victims of Torture, where they get to learn about the true story of what people endure and how it is that people end up here in the circumstances that have led to the lives that people are leading here, like outside of propaganda, noise, et cetera, like in real life form. Who are these people when we talk about immigrants and refugees? And What are the needs? And supporting those communities requires a trauma-informed lens, requires understanding what were the trauma exposures back home that instigated the decision to move for a lot of folks, where literally it was a life and death decision for many of these folks. What were the trauma experiences throughout the migration process, and what continues to happen even in the post-settlement phase after folks arrive here in the US, and really training our medical students to understand what that means and how you can create a space of safety to signal you are good when a patient from these communities comes into your clinic, in your space of work. So we're excited to be able to expand opportunities like that for our learners. And I know my time is short, so I will close us out with this, one of my favorite pictures from one of our now alumnus. She's an alumnus from Morehouse School of Medicine, graduated this May of 23. And she got to spend a year as a Child and Family Health International intern in South Africa, and shared with us this picture of Ubuntu, which she felt it strongly aligns with the ethos of the work that we do at Morehouse School of Medicine, understanding that we are through the collective, that our being is sort of reinforced and strengthened as a collective. And so with that, I will welcome Dr. Barney Graham to share a bit about where we are and where we're going next.
Thank you, Dr. Bastian. You can see why I decided to come to Morehouse School of Medicine. I've spent my career as a clinician, then a clinical trials investigator, then a scientist, and I've now decided that from what I've seen over these years, that I want to spend the rest of it working on health equity, especially what we saw during COVID when we had the technology to develop scientific solutions rapidly, but failed to distribute or make them accessible around the world fast enough to avoid all the waves of variants and so on. So that's why I came to Morehouse School of Medicine. You've seen throughout the day how Morehouse DNA includes work on equity and health justice. So we had an event last year. I came here as an advisor, and then we announced the beginning of this institute about a year ago, the David Satcher Global Health Equity Institute, and it was done in part because of a generous donation from Donna and John Kroll. Their family foundation started us off with a donation. They are pictured in the picture on the right, along with me and my wife and Dr. Satcher and Dr. Montgomery Rice. Next slide. I've got the slides. This institute is based on, the focus is entirely to diversify the scientific and public health workforce. And we do that in these three pillars of focusing first on students, then focusing next on facilitating scientific advance, and then thirdly, which still needs some work, on policy. And the student pillar is what we've worked on most and what you've seen a lot of already today, but it involves educational work. It includes debt relief. Most of our students from medical school graduate with hundreds of thousands of dollars of debt, which restricts their options for what they do with their medical training. And relieving that debt will give them options to do a lot of other things, including science and public health work. Student engagement, this has been driven in part by our new collaborations with the CDC that have been managed by Dr. Chima Owabanwo, who's here with us, part of our team. And he's developed an MOU that not only takes Morehouse to the CDC for a Morehouse Day at CDC, but brings the CDC to Morehouse. And so this new collaboration between CDC and Morehouse School of Medicine has also has a fellowship program within the National Center for Immunization and Respiratory Diseases that we just had a cohort finish recently. You see them in the top right, where they've spent a year with CDC mentors experiencing more basic research in global health. We have the Fogarty fellowships that you've heard about. Dr. Kofi Kondwani, along with Dr. Jonathan Stiles, has developed those Fogarty programs, and you see Dr. Kondwani in the top middle doing that. We've had students returning from Costa Rica where they had an immersion course in global health, and have this incredibly energetic group of students who formed their global health interest group, all of which contribute to that student pillar. The science pillar is shown here, and I'm going to speed along a little bit in the interest of time. And we have spent the last year interacting with science collaborators and friends from Kenya, Uganda, Mali, Senegal, Ghana, and on, and have established scientific collaborations largely through Dr. Stiles' work in Ghana with Noguchi Research Institute, where they're doing state-of-the-art work, including work with him on cerebral malaria, and new collaborations that are being established with the University of Cape Coast. I have been working with people on facilitating vaccine research and vaccine manufacturing capacity in African countries. And I'm just showing you an example of some of the things that can happen when resources are applied and an investment is made. So those three photos on the right show a group at the Institut Pasteur Dakar in Senegal who are building new manufacturing facilities near Dakar on the bottom, establishing mechanisms to manufacture mRNA on the top, and they have recruited back to Senegal Senegalese scientists who had been distributed all over the world. And now that there is investment and resources and opportunities for professional growth, they have all gone back to Senegal to try to make this manufacturing program happen. And that's the kind of partnership we want to have through Morehouse. And then the policy and advocacy pillar, which we need really more resources to flesh this out, but we have gotten some start, and part of that includes telling student stories. And we are in the midst of developing a documentary about the 4 students who helped me at NIH during those first 10 weeks of 2020 to get the Moderna mRNA COVID vaccine launched. And most people don't know that those 4 African American students did most of the bench work and developed the documents needed for filing the IND and starting that first phase 1 clinical trial for the Moderna vaccine. Those kind of stories we think can help change attitudes, and as Dr. Vinson said earlier, that the way you think about things and the way you feel about things changes the way you behave about things. And so these are some of the stories that we want to tell. And we think that Morehouse School of Medicine is uniquely positioned to do some of this work, especially in low-income countries, and is unique because we see our students as the primary asset. And as you've heard, it's a very community-oriented approach to improving health, which is consistent with finding solutions that are matched to the needs in under-resourced settings. There's a dedication to equal partnership and to service, and discerning misinformation and misdirection is central to survival for most HBCU schools, especially HBCU medical schools, and for most of the faculty who have been working here. And as we, in our political life, are stepping away from affirmative action, I think the HBCU medical schools and those programs supported by HBCUs are going to become more and more important, not only for the rest of life, but especially for our health. So I'm going to stop there. I'm going to thank our core team, Dr. Bastian, the Deputy Director of this institute, and we will move on with the program.
And we want all of you to help us do all of that, moving into the future. Dr. Martin, may I ask you to come to the stage? As you heard before, it is simply impossible for us to do this work, to increase these issues, to teach health professionals at the intersections where worlds collide. Impossible for us to do this work alone. It takes partners. And here comes one of our partners, okay? You've heard already, Atlanta is a global health mecca. It is the home of the Centers for Disease Control, the Carter Center, the Task Force for Global Health, Medshare, CARE, Global Atlanta. We have the world's busiest airport and many, many more influential organizations that address the issue of global health and equity. One of those important agencies and partners is the Emory Global Health Institute at Emory University. We are pleased to have Dr. Rebecca Martin join us this afternoon to share the work and the vision of the Global Health Institute, emphasizing its work in immunization. Dr. Martin is the Vice President for Global Health and the Director of the Emory Global Health Institute at Emory University. She is a professor in the Hubert Department of Global Health at the Rollins School of Public Health. And prior to coming to Emory, she had a significant career with the Centers for Disease Control, where her experience there was in HIV, AIDS, immunization, health system strengthening. And she crisscrossed the globe with many different jobs, working in Kenya and Tanzania, Denmark, you know. So please welcome Dr. Martin and her presentation, COVID-19 Offers Lessons for Advancing Vaccine Equity. Thank you so much. Thank you.
Good afternoon. I'm just making sure I can operate the equipment up here. Yes, I have it right here. Thank you so much. First of all, I just want to thank Dr. Graham for inviting me to be part of this auspicious event, your second annual, is it second? Yeah, second annual David Satcher Global Health Equity Summit. What an incredible event this is, and I'm just so honored to be part of this with you today. So thank you very much. What Dr. Graham invited me, he said, tell a little bit about yourself, talk about the Institute, but then you can have your own theme. Well, those are all three of my favorite topics, so this was perfect, and I'm so thrilled to be here with you today. So I wanted to just start with a little bit about who I am. And when I was interested in vaccines, my father was with the Foreign Service, with the US State Department, so I grew up overseas in many different parts of the world. And I remember going back to when I was a child, when we were living in Kabul, Afghanistan, seeing adults and children in the street crippled due to polio. And that was, for me, one of the first things that I recognized and why I wanted to go into health. How that shaped me, I went many different directions, but I ended up in public health and population health in that efforts. I went to get my doctorate focusing in Haiti on high-titer measles vaccine trial that had been done, and following up because we had found that little girls died much quicker than little boys and what was doing with mortality. I then worked CDC, as you heard, and I was detailed to the World Health Organization in East Africa, leading the efforts for polio eradication and for measles elimination in East Africa, the 7 countries. I then moved to Europe and Denmark, as you heard, but really that covered 53 countries, and that was also to look at how do we eliminate measles, how do we there sustain polio eradication, and efforts in thinking about, there was a measles campaign in Ukraine in 2008 where a 17-year-old boy died. It was temporally associated, not directly, but it crashed the entire immunization program, to which it has still never recovered. And then I went back to Atlanta, where I led the Global Immunization Division and led the efforts for all of our efforts of eradication, elimination, and strengthening immunization programs, which really is about equity, making sure every child gets a vaccine. And even to date now, working in vaccine equity at my current position at Emory. So I'm going to start by talking a little bit about the Emory Global Health Institute, which was founded in 2006 by another US CDC director, Jeff Copeland, who recently retired from Emory, but started this in 2006, and really with the ethos of involving multidisciplinary teams to solve global health challenges, and the importance of bringing business and theology with medicine, nursing, public health, importance of how we do this together to solve these world problems. And we have programs, as you've heard, both for faculty and for students, and I wanted to go through a little bit of some of those as we go forward here. One I want to highlight is a program we have for students called the Global Health Case Competition. And this actually came out of the business school, which does case competitions. And they said, one year, we want to do one on health. Well, that led to now, since 2011, we've been doing an annual one. And what's very interesting about this is we make sure that the teams are multidisciplinary students. So we have law students with veterinary, with communication, with medicine. And the teams compete. And this last year we have 32 universities from around the world participate, predominantly from North America and Europe. But we do have some teams from the African continent and from Asia who also participate. And you can see some of the topics here that we've had in our case competition. But I hope this past year we did have a joint team from Morehouse and from Spelman, but I'm hoping we can get more involvement going forward, because this is really an interesting opportunity that puts you on your feet. And I think the most remarkable statement I heard from a student who told me, I didn't really know that everything I was learning in class could be applied. And so me, that really told me, is like, that was important. And working with law students to understand, like, she was really valuable when we were talking about this issue. So I think the value of these case competitions are really impressive, and students really enjoy them as well. Two programs I wanted to highlight. One is our effort with the International Association of National Public Health Institutes, or agencies. And this is something like a US CDC-like, but in many other countries, they're called National Public Health Institutes, bringing their surveillance work with their laboratory, with their workforce, public health workforce, and then the emergency operation systems, bringing this together under one roof and allowing for sustainability across different leaderships in a country. But this is really about building so that when we have and when we occur with the next pandemic, countries are ready. So building the capacity of countries to have these types of infrastructure and skills is really critical. And it's an association, meaning it's peer-to-peer. It's not one country telling another country. They do peer-to-peer, so you can have South Africa working with the Philippines. You can have Germany working with Australia. So there's a real opportunity in this network because it allows for the cross-sharing across actual network institutes. And lastly, I wanted to mention our work in child health mortality. We have now 9 sites around the world, predominantly on the African continent, as you can see, and then we have Bangladesh and Pakistan in Asia. But this is to look at the cause of death for children under the age of 5, and to go beyond the normal verbal autopsy, actually collecting tissue samples and really understanding what children are dying from. And in this process, you can imagine, we have found also it relates to the mother's health and maternal health, which is so critical for the child's health, especially at early age. We are now in our 10th year of this grant that we have from Bill and Melinda Gates Foundation, and we've been given another 5 years with the goal at the end of this that the program office, which is at Emory, will move to either Asia or Africa. So now transferring that capacity and the ownership of this to the respective continents. And I just want to add that all of these data are open source and available. So there are opportunities for people to do additional research, making sure also that data becomes action through policies and through efforts through ministries of health. But it's very, very incredible how from the community to the global level, these efforts have become really important in trying to understand children's causes of death. And then lastly, just to talk, and you heard this also from Dr. Bastien, the importance of the global to local, or as she called it, glocal. And we do believe at our role at the Institute, with research, there's bi-directional research learned. There are things that have been learned in other countries, thinking about PEPFAR that you mentioned, where how to reach into communities has been brought back to the United States to increase coverage for seasonal influenza for elderly people and populations, just as an example. But it's really important of making sure that these cogs all work together. And as Dr. Bastien said, global health doesn't mean across waters. It means something that affects everyone in the world and how we have to all deal with the problem together. So lastly, I wanted to spend some time talking about a topic that I'm very passionate about, vaccine equity. And I wanted to start with noting that this year we saw the expanded program on immunization turn 50. And this was after smallpox eradication. This was the gift to the world, was the EPI, and making sure that kids could be vaccinated. And you can see here how vaccines have prevented 40%, have been responsible for 40% of the decline in infant mortality since 1974. The darker blue line is without vaccines, the green is with vaccines. And we've seen here that measles vaccine has had the largest impact on mortality reduction of over 60%. And I wanted to just talk a little bit about, with immunization programs, there's a continuum. So initially, there's vaccines in development where there may be a high burden disease in thinking about malaria or thinking about Ebola, first of all, and thinking about epidemic or pandemic potential vaccines that people want to make. Then we think about controlling a disease. How do we think about that? And you'll see here programs that have control targets, thinking about the hepatitis, typhoid, tuberculosis. And then when we think about diseases that are vaccine preventable that could be eliminated, we start to think about then elimination targets, whether it's a country, a region of the world, or globally. And then lastly, the ultimate is the eradication. And right now we have polio in there for the human disease to be eradicated. But along this continuum, when there are diseases that have vaccines or vaccines could be made, this is the progress, what could happen as we think about it. But not all can advance to elimination or eradication, depending, of course, on how the disease is spread, the vectors, et cetera, the reservoir. So why do we want to think about eradicating or eliminating a disease? And as we know, it truly is the ultimate definition of health equity. If no one can be infected by it, nobody has to suffer. And it is a gift to the world if we could do this. So this is the real value of thinking about eradicating or eliminating disease. And I want to talk then a little bit about thinking about what it takes to think about eradication or elimination. And it runs from the front lines to the world. It takes the entire globe to do things like this. And in all of this, as said earlier, partnerships are so critical in these efforts. But it takes from science and having quality programs, country ownership. You cannot make a country eradicate a disease or eliminate. If there is not the political will and commitment, it will not happen. And so this is truly important. And then making sure that you have both the human and financial resources. You'll see many things along here, but I really wanted to highlight those as well as the importance of good governance at a partnership level. So thinking a little bit about measles and how it's being eliminated, you can see on the right here the steps that are being taken. The importance of equity, of reaching every child with measles vaccine. The importance of having a program that can be sustained and that can reach every child. And the importance of having community. So again, from community to national to global levels is so critical in all these efforts. And then lastly, making sure that you can track to make sure you're making progress. And this is the Immunization Action Plan 2030, was developed by WHO in partnership with other partners to look at the scorecard and where we're making progress. And you can see, I wanted to bring this up to show you the 3 impact goals. And number 2 is promoting equity. And this is making sure that you can reach zero-dose children, children who have received no vaccines. And the importance also in having a structure where all countries are engaged. And you'll see it's the 1, 2, 3, the 4th box here. The top one is about 50% reduction in zero-dose children. And this is red because it has not been reached, not been able to reach every child with a vaccine. So going from measles elimination, I wanted to talk about the impact of that on COVID-19, in the impact of COVID-19 on measles elimination, but in addition, access to COVID-19 vaccines that happened during the pandemic. And you can see here, we saw more and more cases reported. We thought underreporting was happening because people were not out in the field collecting information. Children missed out on all of their vaccines, not just measles. And campaigns that were to be held to vaccinate children did not occur. So many children missed all of their doses of vaccine during COVID-19 pandemic. And I put this up here. We recently wrote a paper to talk about the lessons that could have been learned to improve vaccine equity in the global south. And on the left are things about vaccine access. On the right, it's really improving delivery and uptake of vaccines and focusing on these specific actions. But the most important thinking on access is we can't have vaccine production in 1 or 2 places in the world. There has to be multiple production around the world, and that is happening now in efforts, especially on the African continent. Being transparent about vaccine pricing. For example, you could have Botswana paying 4 times the cost of HPV vaccine that the UK pays, because all the prices are not shared and not transparent. And so making that transparent so everybody has equal access to vaccines at equivalent prices. And this last one on the left, which was the International Legal Framework, there's a thing called TRIPS, the Trade Representative Intellectual Property Rights. And it was waived for COVID-19 vaccine so that vaccine could be distributed and made. But this is an issue that continues to, with manufacturing the intellectual property and how to protect that, but at the same time ensure that vaccines can be produced everywhere around the world as well. And on the right, which is the delivery, this is again about having strong public health systems, strong healthcare systems that can deliver vaccines, a strategy that makes sure you can reach the kids, as well as ensuring that you're able to then track and making sure that you can track the data and information, as well as communicate and making sure you're using science as you make these decisions. These were all things that were learned during COVID-19 and trying to ensure access to vaccine. But I do have to say, we're now having declared a public health emergency of international concern for Mpox. And what we're seeing again is that over 70 countries outside of Africa have access to Mpox vaccines and have had it for a while. we saw a large global alarm ring because there was a new clade, a new strain of the virus that was circulating. So that got people's attention. And to date, we've seen at least 13 countries in Africa have reported outbreaks, as well as countries in Europe and Asia, currently around 18 countries. And we saw quickly the Africa CDC on August 13th declare a public health emergency of continental security. And then a day later, the World Health Organization declared a global public health emergency of international concern. But the Africa CDC was the first to do this, recognizing that this was not stopping. And when we look at that, DRC has had an outbreak, Democratic Republic of Congo, for almost 2 years now, and did not have vaccine. And as I said, we've seen over 70 countries, low and high and middle income countries, have access to vaccine, but not on the African continent. And why has that been? If we think about the cost of vaccines, well, they're expensive. So this is one issue. So many countries rely on donations or through the purchase, through Gavi or UNICEF or the Vaccine Alliance, and as well as donations from countries or from groups. There's also WHO that does a pre-authorization or emergency use listing. So if a vaccine has not been recommended yet, we have to wait for WHO. And so that has been a bit of a delay, and they have been working on increasing their ability to quickly put in these emergency uses of vaccines if they're not licensed yet. And the third one is country readiness. If you put a vaccine in a country that requires minus 70 degrees storage, and it has to go to remote areas, how do you do that? So that's another thing. Everybody's always like, what is the preparedness in a country to be able to deliver this vaccine into somebody's arm? And this is a really important piece that's been worked on. So to date, I'm glad to announce that 10,000 Mpox vaccines first went to Nigeria, not DRC, where they've had an outbreak for 2 years. And it goes back to the third one. Is the country ready? Could DRC accept vaccines and be ready to deliver them, given the transport logistics that are needed and supply issues? That was a donation by the US. But we did see now early September, we've seen the European Commission did a donation to DRC for 99,000 doses with a promise of more vaccines. But you can just see here how there is so much work to be done here in both in the access to vaccines, the production, the treaties that need to be there legally, as well as the delivery within a country once a vaccine is there. So I'm going to wrap up and just mention a little bit in thinking about, we've seen vaccine nationalism. We need to protect our own people first before we protect others. But if we had given COVID-19 vaccine to South Africa earlier, we may not have seen so many strains come out that then spread to Europe and to the United States. So you have to recognize we are more than just borders around our country. We are together in this around the world. So we think about this in these different situations and what we'll need for future pandemics as well. Walt Dowdle was the previous deputy director of CDC, and he says there is no room for failure. And this is right. We need to make sure every child has access to vaccines, life-saving vaccines, to save their lives and to have productive lives and to produce within our world. So with that, I'm going to say thank you very much. It's an honor to be here with you today. I appreciate it.
Time for 2 questions, and I'd like to ask the first one.
Oh, sure.
Okay. Tell us about the polio rollout in Gaza and the West Bank.
All right, well, she just went to a little question, and I might turn to my colleague Chema too, because I'm sure he's been following. We used to work at CDC together, so I know Chema well. This took a lot of time, and the build-up to think about how do you go into the middle of a war to deliver vaccines. And this was done both in the Horn of Africa, in Somalia before. There were days of tranquility. It was done in Afghanistan, creating days of tranquility. But this is again where health required the ability of negotiations and governance and understanding how to do this. So once you get the agreement, we will have a ceasefire. Then you have to think about how are you going to mobilize, and it takes the community, because you can't send in, health workers, thousands of health workers from around the world. So again, it has to be the community that's driving and leading this. So it has happened, and it started, they got the first and second doses in, but I'll tell you, there have been some incidences where there was still fighting occurring. There have been some incidents reported where somebody was killed who was trying to deliver vaccines. So it doesn't come without a cost. These are very, very critical negotiations. And the importance of, we're trying to eradicate a disease so no child ever has polio again. And the importance of seeing the virus now in this community where it could spread and affect so many kids and make paralysis. So the value of being able to bring this to a health issue, to a global democracy and governmental issue is phenomenal, but it does take a lot of work and effort.
Thank you. Any other questions for Dr. Martin? Dr. Winston, Dr. Thompson.
Thank you. And not just, that's one thing we in the United States export quite well. We have taught groups in Russia, in Europe, and in Africa how to do this, how to be anti-vax. And this is something we have exported to the world, the mis and disinformation. And I'm very concerned about it because it follows along lines with government decisions as well. And so the importance of addressing the mis and disinformation is very, very important so that we can be there. Now, what happens is we tend to put our opinions in journals. We put ours in conferences or meetings. But the people doing this work who are anti-vax are in the communities. They're on the WhatsApp bulletin boards and chats, and that's where they are with the communities. And so we need to be there, not be publishing things over here that are not then brought forward to the communities. So we have to learn to speak at that with the communities, as well as be able to have the people understand kids who didn't die from a disease, and have those parents tell those stories as well, and the value of life-saving vaccines. But it is a very big concern, and it is in every state and also around the world now.
Thank you, Dr. Martin, so very, very much. May I ask Dr. Hernandez-Green to come this way? Now, we all know the headlines. You all read the papers, right? Georgia's maternal mortality rate is among the highest in the United States, and it has been increasing over time. It is going in the wrong direction. Black women are 3 times more likely to die from a pregnancy-related cause than white women. 3 times. And the U.S. ranks 55th in the world. Please, my friend. I'm so proud of this lady. She was one of my earlier mentees. The U.S. ranks 55th in the world for maternal mortality, the worst of any developed nation. Now, I'm going to say that again. The U.S. ranks 55th in the world for maternal mortality, the worst of any developed nation. Morehouse School of Medicine understands the national and global crisis. In 2019, MSM created the Center for Maternal Health Equity to address the national and global issue. Dr. Natalie Hernandez-Green is the executive director of this center and an associate professor in the Department of Obstetrics and Gynecology. She brings decades of expertise in community participatory research, focusing on eliminating women's health inequities. And we're going to welcome her, and her title is Black Maternal Health, Bridging the Gaps and Exploring Global Implications.
Thank you so much. More importantly, what brings me to this work is my own personal lived experiences. So besides being an associate professor and executive director, I'm also the mom to 2 beautiful children. And I've also experienced postpartum depression for both of my pregnancies. And my sister is a maternal near miss, meaning she almost died when she gave birth due to hypertensive disorders of pregnancy. And so when I talk about this work, it's more than just work. It's a personal mission for me, for my family, and the communities that I serve. So who are we at the Center for Maternal Health Equity? So we actually got our appropriations from the state in 2019 to address the inequities that we were seeing in Georgia, being Georgia has one of the highest rates of maternal mortality in the country. But we actually didn't really get started into 2020. I was made interim director in March in 2020 during a global pandemic, and was told, okay, we're gonna start the center, and then 3 days later, the whole world shut down. And so even through those experiences, I saw that as an opportunity to really focus on not just maternal health, but the intersection of what we call the racial reckoning that was happening in the United States, as well as COVID-19, because a lot of people weren't doing that work with pregnant and postpartum populations. So our center does our work in 3 different ways. A big component of what we do at the Center for Maternal Health Equity is focused on research. We have about 10 active research projects. A significant amount of the funding for those projects are restricted from NIH funding, and so we do receive a significant amount of NIH funding, but we do have a diverse portfolio of funding, which helps us to be really innovative and creative in how we do our programming and even how we do research, which a lot of government entities won't fund the type of research we like to do, because we're trying to be bold in this next iteration, because we're tired of seeing Black women and birthing people die from what can be 80% preventable causes of death. In addition to that, at the heart of our center is the community, and so we do engage in a lot of community engagement, and I don't like that term too much. What I like to say is that we're building bridges and partnerships with our community. We're really intentional about how we work with our communities, and then using a model of for us, by us. If those of you grew up in the time that I did, you remember that brand as FUBU. And so we're in the FUBU brand of how we do our work, and ensuring that if anyone's gonna be creating solutions with our communities, it should be the people that look like them. And then third, we are an academic institution, and so a big part of what we do is around training. We've developed 3 of our own training programs to really think about how we're diversifying the perinatal workforce and really building on the strengths of communities. And so doing a lot of work with paraprofessionals, but then also getting a lot of our departments that tend to work in silos, working together on such an important issue that all of us can relate to, because we either have a sister, a mom, a cousin, an auntie, a granny, so we all can relate to women's health. So over and over, we've seen these headlines, right? Like, nothing protects Black women from dying. And it's really striking to know what's happening. But globally, it's even worse than what we can ever predict that's happening in the United States. And one thing that we've been doing with one of our major projects is collecting stories from women of color across the country. And I'll talk about that a little bit. But this quote really summarizes a lot of what I'm gonna tell you today. And it says, it's from a Black woman in Brazil, and this is from a report developed through the United Nations that was looking at maternal health of Afro-descendants and African women across the Americas. And this quote says, "You notice that when a lighter-skinned person enters the room, the health professionals take more time with them, but when a Black person enters, they look to leave quickly. When inside, the health professionals don't fully examine the Black person the way they did the lighter-skinned person. You understand? That is why there's this difference." And that's a Black woman from Brazil. That's what we heard from 140 stories that we collected from women across the country here in the United States. And so there's a lot of similar things happening globally that are happening here. And so when Dr. Bastien mentioned global, I mean, it really is global, right? The same exact issues that are happening across the world are happening here in the United States and in Georgia specifically. So Virginia mentioned maternal mortality rates in the United States. Over the decades, we've seen it get increasingly worse, and then of course, COVID-19 added to those rates. But in 2021, about 1,200 women died of what we call pregnancy-related complications or maternal causes. And what's stunning is that more than 80% of these are preventable. And there are inequities when it comes to maternal mortality and morbidity, where we know that almost Black women are 3 times more likely to die from pregnancy-related complications, as was mentioned earlier. In addition to that, we know that particularly institutionally or politically marginalized communities, but historically resilient communities are really bearing the brunt of this maternal health crisis. And it's not just with Black women, but we also know that Indigenous and tribal women are also experiencing the same inequities, and we're starting to see increases in maternal death among a population that was normally to be the gold standard of what maternal health looks like, and that's the Latinx population. And in Georgia, we've seen actually the increase of maternal deaths with that community. Globally, it's a completely different story. It's unacceptably high. We have a true crisis happening globally. About 287,000 women died during and following pregnancy and childbirth in 2020. And globally, a maternal death occurs almost every 2 minutes. Think about that. Every 2 minutes, a woman or a birthing person is dying from pregnancy-related complications. And for every woman who dies, between 20 and 30 will experience injuries, infections, and disabilities. And like as I mentioned before in the US, what's unacceptable is that most of these deaths are preventable. 95% of maternal deaths occurred in low or lower middle income countries in 2020. And as I mentioned, almost 90% of those deaths could have been prevented. What we're seeing commonly across the globe is that the number one issue and what's contributing to maternal deaths is inequalities and access to quality health services, which really highlights the gap between the rich and the poor. And that's something that we also see in the US, although it's a little bit more complicated than that. And the major complications that account for nearly 75% of all maternal deaths are severe bleeding, infections, usually after childbirth. And we know that the majority of maternal deaths actually happen after a woman gives birth. Hypertensive disorders of pregnancy, and unsafe abortion. The Lancet Global Health also looked at social determinants of health and how that contributed to maternal deaths across the globe. When we know actually in the United States, the social determinants of health that are supposed to be protective are not protective for Black women in this country. But globally, things that we know about where you work, live, eat, play, pray, contribute. In addition to that, there are a lot of gender dynamics that happen globally that contribute and that lead to favoring sexism and gender injustice, racial and ethnic dynamics that favor racism and discrimination, hunger, corruption, armed conflict, violence, as well as the other factors that we know that tend to contribute to maternal morbidity and mortality. This is another graph from that United Nations report where Figure 1 reports pregnancy-related deaths for women and girls in 3 of the countries that actually publish race disaggregated data. Because one of the gaps that we have around maternal deaths is that we don't have valid ways of collecting this type of data. And so it's pretty skewed depending on what countries you go to. But in these 4 countries actually disaggregate the data by race and ethnicity. And as you can see here, the same inequities we see with Black women in the United States is the same thing we see in other countries, and also in Brazil as it's broken up here. The literature on pregnancy-related deaths particularly across the Americas, of those of Afro descendants, are pretty much the same that happen in the United States, where the leading causes are related to preeclampsia, eclampsia, and other hypertensive disorders of pregnancy, as well as cardiovascular conditions. But these outcomes for Black women in the Americas is up to 5 times that of white women and girls. And one thing that we don't talk often that more women live with is severe maternal morbidity. And so there's a lot of attention on the deaths, right? Because that's something that the media could really run with. It really pulls at your heartstrings. But for every maternal death, there are 50 to 100 women that experience severe maternal morbidity. And that's supposed to be an underestimation. They feel like those numbers are actually quite higher, because a lot of this is documented in hospital deaths, and not everyone gives birth in a hospital. And so there's underreporting in that. And the same inequities we see with maternal death are the same inequities that we see with severe maternal morbidity. But a lot of the information that you don't get from that, and I'm sure Dr. Vincent mentioned it earlier, was the trauma that comes with living with these severe maternal morbidities, these complications, but the trauma from some of their birth experiences as well. You know, I love this state and have decided to raise my family here. But it's a pretty scary state for a lot of people, because we are considered to be one of the most dangerous states for pregnant people, for pregnant women and people. Georgia has among the highest pregnancy-related complication, maternal health death rate, with a rate of Black women also experiencing 2.3 times that of white women's. Factors that contribute to this is that we are a state that didn't expand Medicaid, and so we do have 20 to 30% of women of reproductive age in this state that do not have access to any health care insurance. There's a low proportion of reproductive health needs being met by publicly available health services. We also know with the recent March of Dimes report, as well as the previous year's March of Dimes report, is that we have almost half of our counties without any type of obstetric provider. There's a low proportion of women with a dedicated healthcare provider, why primary care is so important, and a low attendance of postpartum care, which is something that we've been struggling for a long time. 76% of the counties in Georgia have no hospital or birth center that offers maternity care. And we can create the best physicians and put them out there, but a physician is just as good as their healthcare system. And so we need to make sure that we're also investing in our healthcare systems. As I mentioned before, with the leading causes of pregnancy-related deaths, if you take all of the data, most of it for Black women is on these sort of cardiovascular disease conditions. Few causes contribute to the overall Black, non-Hispanic, and white, non-Hispanic white disparities, which again are the cardiovascular conditions. But in addition to that, you know, other things that we talk about are, you know, your age. And so, you know, a lot of us who maybe had children in 35, we were considered advanced maternal age. It increases your likelihood of suffering from a pregnancy-related complication. There's been an increase of cesarean sections that are happening. Substance use and mental health are now some of the leading causes of maternal deaths in the country. But all of this still doesn't explain why Black women are almost 3 times more likely to die. And that's the United States. You go to places like New Jersey, Black women are almost 7 times more likely to die from pregnancy-related complications. And so a lot of this is what we call these drivers of maternal health inequities. The reproductive health of Black women has long been compromised by interpersonal, institutional, and structural racism. In addition to contending with social and economic drivers of poor health that undermine Black Americans, they have experienced discriminatory healthcare practices and abuse from slavery to the present, from non-consensual medical experimentation to failing to listen to patients or providing an adequate standard of care. Healthcare itself has been a driver of death and severe complications that Black women and birthing people face. A lot of these historical and economic forces, including restrictions on housing options, all of that have contributed to a lot of the inequities that we see. Another driver that doesn't get spoken a lot about is the weathering hypothesis. This is the impact that high-level chronic stress caused by just being a Black person in a racist society. And that causes what we say the weathering of the body. The term weathering describes how constant stress of racism may lead to premature biological aging and poor health outcomes for Black people, like we see with disproportionately high death rates from chronic conditions such as heart disease, stroke, diabetes, and most cancers. And the mental anguish and stress from fighting against larger structures and systems can have an impact on your health. And this is not to say that it's not that every Black person has more damage than every white person. It's really about how much stress versus social support you get in your everyday life. And because Black Americans and lower income Americans are more likely to suffer more of these stressors, they are more likely to be weathered severely, and weathered at younger ages. The other thing we know, and these are actually real pictures from the textbook, is that bias, unfortunately, is ingrained from the very beginning of medical training. There was a 2016 study of 418 medical students at the University of Virginia, which revealed that more than half of them endorsed at least one myth about the physiological differences between Black people and white people. And that these false beliefs are related to racial bias in pain perception. Then there was this study that looked at the obstetrics medical textbook that's used. And it looked at 17 of the 20 editions of the Williams obstetrics book. And they found that in these pictures, white females tended to depict healthy pregnancies, while pictures of Black women depicted abnormal or unhealthy pregnancies. So y'all saying, okay, Dr. Hernandez-Green, all this bloom, doom, like what are we doing about it? Because we're in the business of creating solutions. We know the statistics, we know that this is occurring, but what are people actually doing? And there's a lot of great work that's happening out there. And what we love to do, again, is partner with national organizations as well as community-based organizations that are doing this amazing work. But what the strength that we know we bring is advancing the science as it relates to creating these solutions. And so one of our first and proudest initiatives is our Center to Advance Reproductive Justice and Behavioral Health among Black, pregnant, and postpartum women and birthing people. Yes, we love acronyms. Don't ask me how that acronym makes sense, but it does. But we were fortunate to be one of the 12 NIH-funded Centers of Excellence in Maternal Health Research. One of the 12, there's 2 HBCUs that were funded in this initiative. We saw that, again, the leading causes of maternal death now were going to be mental health conditions or behavioral health conditions. And we were really afraid that because that rose to the top and that the numbers didn't really portray Black women as experiencing a lot of these maternal mental health conditions, that we would be left behind again. And so we wanted to make sure that we were ahead of the game, that we were going to be the leaders in addressing Black maternal behavioral health. And so our mission is really to help Black women not just survive, but thrive while being pregnant and in the postpartum period. We do this work, again, working in collaboration with communities who serve as our governing board So we call our community organizations our community accountability board because we want them to hold us accountable for how we do research and how we work with communities around research. We also want to train the next generation of early stage investigators that look like us, because again, oftentimes Black and brown women that look like me are brought in an advisory capacity, knowing full well that we can lead the research because we've been in those oppressive situations and know where the solutions lie. And then building the capacity of not just early stage investigators, but the investigators in our community organizations that are currently doing this work. And so it is a huge collaboration. We have about 65 partners across the country that are working with us on this initiative. The next initiative is expanding the work that we do in rural communities. And so we were blessed to be funded by HRSA to really think about how we're expanding this work among Black rural communities. There was a report that showed that while a lot of hospitals and birthing centers were closing, the majority of them were closing in historically Black communities. And so it wasn't just a rural thing, but it was a Black rural thing that was occurring as well. And so this grant expands the work that we're doing. We're conducting listening sessions using methodologies that our communities are really excited about, including photo voice, because again, how we do our work is really centering, elevating, and amplifying the voices of those that are affected by the issue. And through this network too, we also are able to develop a project, and in that project we're incorporating partners and fathers and really listening to what Black fathers have to say and how they can be a part of the solutions for our Black mamas. Our next project, as I mentioned, 20 to 30% of women in the state of Georgia do not have access to care. And so we had to figure out ways to meet people where they're at. And so we took an evidence-based intervention like preconception counseling, we adapted it to be culturally relevant, and we'll be implementing it in community-based settings, because we knew that our women and people were going to these centers to receive services, so why not get them where they're already accessing services? And so we're using the model, the expert model, and screening women. We're trained people from these local organizations to serve as facilitators and basically community health workers that are delivering preconception counseling. And then we're connecting them to healthcare services like federally qualified health centers so that they can be engaged in care that they can afford, or as at least on a sliding scale. And so this project tests the implementation of how you do this, as well as look at effectiveness outcomes, because again, they always say there are a lot of evidence-based interventions, but for whom? Because were we included, were we well represented in a lot of these clinical trials that are happening? And so it is a hybrid implementation science trial that's looking at effectiveness outcomes and as well as implementation outcomes, so that we can scale it up. And this is happening across 4 other southeastern states. And just so you know, 56% of the Black population in this country live in the Southeast. And the last project, I mentioned we have a lot of projects, but I only wanted to highlight a couple, is our community-based perinatal patient navigation program. Prior to doing work in maternal health, I worked in the cancer space with our Cancer Health Equity Institute. And one of the projects and things that I've done also in a civil rights organization that I used to work at were patient navigators, or the utilization of community-based workers. And I was like, well, why isn't anyone doing this in maternal health? Like, you take people with lived experiences, you train them, you amplify them, and now you have someone that can go through this pregnancy journey and assist women. And so we thought it was important to train people that look like us. And so we, again, train women from the local community. We train them as community health workers. We train them as community-based doulas, lactation peer support specialists, as well as patient navigators. And so they even learn how to work with electronic medical records. And the point of these navigators is to do assessments around social determinants of health, some clinical situations, provide health education to them, and then really the navigators serve as a tool to activate the power that communities already have. Because we're not here to empower people, but we're here to provide them with the tools to activate the power they already have. And so this has been a really exciting program. We've trained over 70 women within the state of Georgia. And we're looking at adaptations to work with different immigrant and refugee communities, because this is something that they indicated that they would like within their own communities. We have employed 7 of these community-based perinatal navigators and are currently working on policies around reimbursement for each of these different trainings that they go through, and why I thought about the training to be more holistic, so that if we're reimbursing CHWs, now our navigators can reimburse. If we're reimbursing doulas, now our navigators can be reimbursed as doulas. We also have an NIH R01 to test the clinical effectiveness of it, because I can't go to policymakers and want to implement change if I don't have data to show that it actually works. And so we're really excited. We're in year 2 of this clinical trial to test the effectiveness of this program to see if we can reduce severe maternal morbidity and mortality, which is a big thing to look at as an outcome, but then also process evaluation. And so how would you implement this? Because one thing that hasn't happened with a lot of these navigators is that no one's really integrating them into clinical-based settings. And so our navigators are now integrated at Grady, Atlanta Birth Center, Morehouse Healthcare, as well as 2 FQHCs. And then the last project I'm going to highlight, which is actually one of our first projects, which informed a lot of the interventions that we created, because again, we create interventions based on what the community identifies as a priority, is our maternal near miss. And one thing that I love as being trained as an anthropologist is stories and narratives. And to me, stories are our life's blood. It's how a lot of our communities have gotten past our traumas. And so we wanted to use a narrative-based medicine approach to really get at women who almost died from pregnancy-related complications. I was really tired of being on the state's maternal mortality review board and not hearing from that person's experience. I was like, it's too late. Like, it's great that we're asking the moms and the dads, but why aren't we asking people while they're alive? And so this was a way to really codify people's birth experiences and use them as data points to really affect policy, practice, and different healthcare strategies that we can utilize. And as you've seen, that narrative project, the first phase, was really the impetus and what informed all of these projects that we currently have at the center. And so we did a phase 2 because we also heard from fathers, we heard from maternal fetal medicine specialists and nurses. Like, we want to tell our stories too. And so phase 2 incorporates all of these different types of stories. And one thing that we're proud of is that we're also talking to children who are the result, well, now adults, who are the results, or their moms died from pregnancy-related complications, to see what their life trajectory was like. And a lot of this was happening globally, but no one was really doing this in the United States. And so we're really excited about that project and what it can lead to, and how when we think about the aftershock, right? Like, we forget that there's a family that now has to live in a world without their mother, and no one's really addressing what's happening with that family. And so we wanted to be there to collect data to see how we can inform different strategies. We've also been creating case studies and working with our Department of Obstetrics and Gynecology to see how we're going to test it. How can we work across different departments? How are we thinking about multidisciplinary teams to really address an issue that requires all of us to be partners? And the last thing is, like, recommendations. What can you do? Again, as I mentioned, we do have a lot of projects in which we're working with Embrace and Latino Community Fund on really thinking about working with communities, again, that are often left out of this maternal health picture, and that we see rates starting to increase, particularly with a lot of anti-immigrant and anti-refugee sentiment that's happening in our state and across the country. And so some of the recommendations that I want to talk about and leave you with that are not just with Georgia, but globally, is access to care. We need to ensure universal access to not just maternal care, but contraception, to what we said, the preconception counseling, because it's too late to address maternal health when a person is pregnant. This needs to happen while in utero, right? We need to be protecting people before we even give birth. Emergency obstetric care, we need to provide timely care. What we keep hearing is that people are not reaching their clinics in time, or they're not aware of the warning signs. And so how do we deliver timely care to our communities so that there aren't these complications like hemorrhage and sepsis that we have recently been hearing about? And then we need to really think about diversifying the perinatal workforce. We're not going to train enough physicians, and especially racially concordant physicians, to deal with this crisis head on. We have to think about how are other countries doing this. They're using community health workers. They're using skilled birth attendants. I mean, these are things that we can be implementing that are low cost and can really save hundreds of lives. And then focusing on that postpartum period. Again, you know, we send women home and then you're off on your, you know, by yourself. And everyone loves a pregnant person, but once we give birth, that's it, right? Everyone pays attention to the child and they forget about us mamas here who are struggling on 3 hours of sleep, breast hurting from breastfeeding, and just feeling so alone and uncared for. And this is actually the most critical time. And so how are we thinking about the fourth trimester? How are we thinking about providing not just medical care, but social support care and dealing with a lot of the struggles that mamas have to deal with in the postpartum period? And then lastly, accountability. There's a lot of great programming that's happening, but it's like Dr. Martin mentioned, like we're just sharing it in peer-reviewed journals and nothing is getting back to our communities. How are we holding people accountable who get federal grants to make sure that they're actually implementing change? How do we hold each other accountable when you see someone being mistreated at a healthcare facility and you're standing up for your sister or your brother who's about to lose somebody? Accountability is something that we all can be a part of. And it just takes for us to speak up for those who feel that they have not been listened to. Thank you so much for your time, and I really appreciate you all. And let's make sure that in 5 years, we're not hearing about another mom who's dying from something that's preventable. Thank you.
Any questions? I have one. I always have one, don't I? Yeah, okay. And it really comes from Sister Song, Sister Love, and Black Mamas Matter, okay? And that question is, you mentioned the Georgia Mortality Review Committee, and they would like you to link that official government entity to say her name, Amber Thurman.
Yeah, so we're really excited. There's these amazing reproductive justice organizations are actually going to have been galvanizing and been doing this work for a long time, and we've been fortunate to be able to partner with them. And so if you're interested, there will be a rally on Saturday for the 2 women who we've lost, unfortunately, to preventable causes of death, and I can't really get too into it. But again, healthcare is healthcare, and no one should wait until someone is about to die to provide the necessary care that they need, so that we're not continuing to lose people for something that's just so simple in providing care. And so I think when it comes to accountability too, I think as healthcare providers, there also needs to be a lot of knowledge on policy and what those policies mean when you practice medicine or when you're working with these communities. And again, it takes all of us to be brave and strong to say, like some of our dope OBGYNs that we have at Morehouse School of Medicine, I'm not gonna wait until someone's nearly dying to provide them the necessary care that they need. Yeah, so we're actually gonna be putting out applications for our next cohort. And so if you go to our website, which we're still updating and working on, there'll be information for the next cohort, and that'll be throughout the state of Georgia. And then as I mentioned, we're working in Texas and other states that have high maternal mortality rates to scale up the programming. So it's free, the training is free, and you actually get a stipend. And then we work with you, thanks to some of our funders, where if you're not employed by the healthcare system, we do help you to develop an incubator and your own business. Yeah, that's a really great question. I know that there have been a couple of surveys conducted with the National Medical Association. I think about 3 years ago, there was a report that the OBGYN section put together about sort of what you're getting to, Dr. Thompson. But there's been no official survey conducted, particularly with our Black medical schools. We do have an HBCU alliance on maternal and child health that's headed out by Dr. Bronner out of Morgan State University, and that's something that we did consider discussing. But there is a lot of data that has shown that when you have a racially concordant provider, outcomes are improved, and we've seen that with infant mortality. I think people are still working on that for maternal mortality. But I do have to say that, you know, in spaces where we share how we practice, we do know that we have better patient satisfaction surveys compared to other providers that practice in that same space with us.
Now, do you see, this is just one of the many programs that we presented today that show you that we at the Morehouse School of Medicine take global health, equity, and justice very seriously. I'm going to cut into your break. It's break time, okay? But I need you to come back because the next section is even more exciting, okay? Breaks here are drinks over here, bathrooms are that way. Don't forget to scan the code. Thank you very much for being here. Back in 10 minutes.
Profitant de son séjour au mois de juillet à Kinshasa, en République démocratique du Congo, le docteur Rigobert Lam, cardiologue et professeur de cardiologie aux États-Unis d'Amérique, a dû travailler laborieusement en menant des consultations de malades gratuitement. 350 personnes venues des 4 coins du pays ont bénéficié de ces séances qui se tenaient dans l'enceinte de la paroisse Sainte-Anne de la Gombe, à savoir
Five minutes and counting. 5 minutes and counting. You can't go nowhere. But I'm getting ready to get back up there now. Can we regather, please? Put on tape. Ladies and gentlemen, before I forget, at the end of the closure of today's session, we are going to put a QR code on the screen. It will take you to a survey evaluation form that we would like you to complete to help us understand how to make this better and what you liked and those kind of things. So please, we'll put that up at the end. Okay, here we go. You know, there are some folks who truly believe in building bridges, going the extra step to make things happen. A calling that just sometimes defies logic. So as you review Dr. Lapu's bio, you're going to read about his extensive work in cardiology and his leadership in Morehouse School of Medicine's NASA Human Cardiovascular Studies program. He is an associate professor in the MSM Department of Internal Medicine, the Division of Cardiology. But allow me to tell you the behind-the-scenes story of his work in the Democratic Republic of Congo. He had a vision and a dream to improve the health of the population of his birth country. He literally saved his pennies, purchased and equipped an ambulance, and shipped it to DRC. Honest story. There he forged partnerships and began providing direct care to the population. He began this journey with only support from his family and friends. But today, you will hear the story of how one ambulance grew to two, how he developed partnerships with NGOs and the government, all to serve the underserved populations of the Democratic Republic of Congo. The Morehouse School of Medicine Global Health Equity Institute is very proud of Dr. Lapu and the work that he has done in DRC, and we asked him to share it with you now.
So we say merci beaucoup. So you don't need to say in French to come with me in Congo, okay? But you're going to be with me in Congo, okay? Bon après-midi, meaning good afternoon. We good? So thank you again for the great presentation. So today we're going to have a chance to share a lot of good stuff here. So you can see here we're talking about cardiovascular on purpose because I'm a cardio guy. Okay? And that's the reason why I put my very unique stethoscope that make miracle when I go to Congo, okay? Now, we're talking about the DRC, and you heard about the DRC a few minutes ago, Dr. Rebecca Martin talking about a vaccine issue. They don't want to take a vaccine. They say we don't want it because anti-vax movement coming, people are afraid of a lot of things. So the same thing for me, I need to go convince them to take modern medicine, but now bring some phyto medicine, plant-based medicine. You see how cheap it is and how good they can relate with us. We good? And then you see we're talking about the bridging and fund solution. It's not by accident. One of my foundation in the Congo is called Forilas, S as a solution, okay? In what? Yes, to provide as a clinician, scientist, and an educator. I have a triple mission all the time. I've been working on a triple threat, we call it in medicine. So patient care, teaching, and research, like any other clinician, okay? So we're gonna provide all these aspects in this presentation. So the adventure started, we see that in a minute. I was thinking, should I go with LLC, which is I teach with video, teach with this. I need the technology, so this platform is not meant for people like myself where we do things, okay? But anyway, we're gonna try the best to get that across. So I was thinking about the LLC, but at some point, I scaled this up to go to global health, non-profit, from here, from United States, okay? So I can go across overseas. And then you will see my foundation called. Now, accessible or access, this is RLS Rigobert Lapo, access. Of course, we have been hearing about the access. It's not a new concept, but it's a concept that is going to apply here. Now, when we go to Congo, we're going to do the same thing. So meaning our learners, students, faculty who come with me should be able to apply there and here, back and forth. We good? Because it's the same concept now, be tested somewhere else. So when you say access, you can read. I'm a founder of this global health nonprofit because I need to provide cardiovascular. Now we go even further, cardiometabolic services. Through what? Through patient care, of course I say that, through education and science as a clinician, scientist, and teacher. We good? So here we are. My stethoscope is on my neck. The ambulance is already in the Congo. So the ambulance is in the Congo. I was thinking at some point that I will go just do a cardiovascular business. But at the end, you will see that is more than that. And this is good news for our student, our learner, because they can be exposed to different things. One of the projects I will not go to detail is ACT. Okay, ACT is to change because you want to change the world. Not on that order, but you need to change it in a good order. We good? And then, of course, there are many places we could go. And today we're going to focus on one of the countries here that is called, here in blue, Democratic Republic of Congo. I'm in a good position, of course, to go through this because you can see I was trained here in the Congo Democratic. This is my university for Kinshasa. And then I went on to Belgium to do my cardio internal medicine and the cardio fellowship. Now, people were dying for heart failure, and then we need to give a new heart. I was asked to go and then do different testing so we can select the patient that need the most the heart, because to give a new heart, someone has to die. You cannot give it like handy. So I have to do a PhD to understand those individuals who should need a new heart. So take them from ICU, do all the testing from a cardiovascular standpoint, and determine you need a new heart, you don't need one, and then we send you to surgery. So after the PhD, so 10 years in Belgium, I was selected to join Morehouse School of Medicine because by the time I was doing PhD, I was coming twice a year in November and March to present my work to the American Heart Association November and the American College of Cardiology. Very outstanding business, as you can imagine. People are almost dying in the ICU. I have to get them and put them in a treadmill, exercise to determine. They cannot do it, but some will do, others will not do, and that's exactly the point where the world needed this answer. So I came to Morehouse School of Medicine, and to use my knowledge as an echo guy, because here I was doing non-invasive technique like an ultrasound, and then here we did a lot of NASA projects. You can see here we're testing. So meaning from Belgium, where I'm seeing patients at the end of the spectrum, they're sick, dying, come back to the United States having a healthy individual, test blood pressure regulation, doing exercise, doing salt sensitivity. That was the early stage. So you see now how I'm in a good position going back somewhere in the many countries to talk about preventive medicine instead of just waiting for people to get sick. We good? So here, of course, joined Morehouse School of Medicine. Now I'm giving back to my country as a professor and as a clinician with now my ambulance to provide care to the population, as you can see here. So this shows my trajectory. So MD in Congo, then to Belgium from cardio, and then become PhD in Europe in Belgium, and then joined the Morehouse School of Medicine as a postdoc and the NASA. So it was a good start as a consortium because I've been working back in many places at Morehouse, at Brigham, Cleveland Clinic, NASA Ames, Silicon Valley, and I was going, name it, Alabama. I was going week here, week there, week everywhere. So it was the time we didn't have internet. Before 1999, 2000, I have to go all different places to do the work, eco-occupation, do all kind of stuff, and the science. So meaning I'm in a good position to talk, to have this experience on a global F, as you can see here, from Africa to Europe now. Now, again, I will just apply my triplet threat, we call triplet threat academic skills. Why? Because as a clinician, educated scientist, we provide three things: care, teaching, and research in various percentage, okay? So in a Congo, it's going to be all the three, not to mention the administration part of our business, okay? So when I go to Congo, I kind of tell them the story, say, we as HBCU, we welcoming diversity of culture and idea. So meaning I'm coming in Congo for our student, our learner. Don't think that we're coming to pick your job. Don't think that we're going to kick you out of your business. No. we're coming just to share. Look how we are here. As you can see on the screen, culture-sensitive individual and culture-sensitive business, medicine, teaching, and kind of research we're good. So we're coming to help you. And as you can see here, we did some research on equity through clinical research education with all our beautiful mixture of future learners and the leaders in a variety of culture, bringing a lot of good ideas. So it's a good time to go with them. Sure enough, that's my business model. Back then, I was thinking about, first of all, the first model is we need to make a diagnosis. That's why I bought the ambulance. And then the last step is going to be at least bring the EMS. This ambulance is in Congo already. I'll be using it. This one is still here in my house in Atlanta. I need to ship it soon, okay? Once all the paperwork finish, my government is going to go. So this one a high-tech EMT, so EMS system, so emergency system, as you can see here. Now, in between, we train our students. When we say student learners, think about it as the Morehouse School of Medicine, United States and Africa, DRC, and soon enough with Dr. Style, we're going to bridge to Ghana, and then, of course, India. We will see that in a minute, okay? So our first time is going to be focused on this part where we're going to be just doing the mobile unit to combine diagnosis and so on, and the rest is going to follow for the next. This is the take-home message up front. Since I started this adventure. So here we're talking about COVID. The idea comes from family members say, hey, can you come, let's go do business in the Congo. As a cardio guy, let's just go do business, profit, okay? So I start learning about things. We were confinement, no moving. And then I said, Lord, if this is my calling, show me a sign. For some reason, I was thinking about, the Good Samaritan, right? It was in the floor. Everybody was passing. Nobody wanted to do it. And then, the priest went away, the other guy went away, and then someone, the Samaritan, was a bad guy, so to speak, but came, attend this person, and put in an animal, bring to the inn, and then go. So I said, oh, that's my story. If that's true, because many people don't want to go back to their country. They say, oh, don't forget about it. You are American now. You've been in 10 years in Belgium, 20 United States. What are you going to do in the Congo? You're not going to survive that environment, okay? So that's exactly the spirit of the Levite, the priest, leaving the guy on the ground. And then the Samaritan comes and says, oh, God, that's a good idea. So meaning, if I go for an ambulance story, it should be fine. So first attend to them, then bring them to a center, and come back for continual care. So that's the idea I was taking my ambulance. So the question was, Lord, if that's true, I need to buy an ambulance in Atlanta, not anywhere else. Before you know it, I was Google, and then I found the ambulance. So I said, hey, there's an ambulance here. I said, is it free? I said, yes. I went down close to Grady somewhere, and then I found this ambulance. So this is a big story. And then I get my ambulance. I ship it here in the Congo, over here. And then as you saw my first slide, I was thinking about LLC. Why not? And then over time, I bought the second ambulance. It's going to be more EMT, and then made a trip in the Congo, if true, to go test the water, see if it's going to be possible, those kind of business, okay? So I went there, and then I did the first thing, talk with in the medical school, University of Kinshasa, where I was trained. You saw my picture, talk about this idea. And then from there, I returned back. So it was well perceived. I returned back. Now, the Archdiocese of Kinshasa in Congo and the Archdiocese of Atlanta came together to help Congo have a medical school from the Catholic University of Congo. And that's the reason why a group of individuals get together, invited me to be part of the board so we can help. And then, of course, from there, I was part of Morehouse School of Medicine Global Health. So I became Global Health team, and then I changed the idea of LLC to a Global Health non-profit because I need to provide this service down there. Now, up to last year, and then I went back the year before, many people say to survive this environment, you need to have some sort of NGO, association, and everything. So it was an idea for me to create what we call foundation, which is Rotavirus. So all this is going to happen in the United States of student learners, but we need expertise on the ground. That is why the foundation is going to take over with good expertise on the matter that occupy the Congolese people on the ground. So we get that foundation. You will see, this is in French, you say foundation, but in English, you're going to put you foundation, okay? So you don't need to learn English to know that is the fondation. It's a foundation. Fondation is in French. Now, the log I can explain. My heart is there. Now, I'm pulling someone who's in trouble to get out of trouble. So meaning, the concept of my ambulance is, or our ambulance now, is you come in sad, you leave happy. You come in trouble, you leave fixed. We good? So that's what we're going to be seeing the couple of slides. I have a web in progress right now. And then, of course, as I mentioned, Rotavirus is going to be providing education, care, and science based on my, my interest. So you're going to hear about access. So a lot of our students will say, Dr. Lap, we're going to penetrate the Congo. That's the point. And then I found this slide interesting to say, okay, penetrate the Congo, but penetrate Africa and the world. So we're going to start here because I'm familiar with the Congo over here. And then over time, we're going to expand our idea to penetrate the Africa and many other places in the world, okay? So that's the concept. So how are we going to fix that problem? This is what I call agitation, okay? So I need to challenge our students that we have a three set of problems. Most of the time, we're afraid of talking economic. That's why I put socio-economic, because our government, our foundation is going to be supported by Social Affairs, Minister of Social Affairs, and the Minister of Health. So those now are putting paperwork for me so we can start putting our program together to support a good program. Okay? So it's a good idea to give you just a sort of why you need to support this country, why we need to do something. We're enjoying, it used to be, we call it a blood diamond, because our jewelry, our watch, good diamond coming from my country, Congo. And people have been dying for that. Now, the other reason is now, we're enjoying the laptop, we're enjoying phones, and all good things, NASA space shuttle, all space station, because of this mineral come from coltan. But this girl has been working, losing her husband, needs some help, needs to be in good shape so she can do what we're enjoying right now in terms of all the resources. The other thing is my country has a superpower, hydropower, which is underutilized. Can you imagine Congo is able to serve the entire Africa in terms of electricity, but only a 2.5% of potential has been developed. So we need manpower. We need individuals to be healthy so they can work. So people not healthy no work, so that's why the prevention come handy. So those are the economic reasons. That's why I'm being supported by Social Affairs. You will see in the end, I was able last summer to meet with the minister because we have a new government just get installed right now. They're getting situated, settled. And we will go back and then do some project with them to support the foundation and our students, of course. Now, the other issue you can tell is the mega city. So mega city meaning mega problem. Kinshasa is one of the three countries in Africa as a mega city, meaning what? 10 to 15 million people living in one space. This is not a country, one small space. Now, in European country here, United States, people will go like this to house them. In Africa, we need to go this way. That start posing some problem. So here, Kinshasa is a beautiful city, it's a mega city, so we know Cairo in Egypt and Lagos in Nigeria are the three mega cities in Africa, okay? So the issue is simple, we have a job issue, but I'm gonna focus more for our healthcare, okay? Now we're talking about the heart. Yes, it used to be what? If you see the left side, the paradigm have shifted. We see heart disease everywhere, except in Africa, it was more infectious disease. We talk about malaria, HIV, and tuberculosis. But now, the picture can tell is the cardiovascular disease is taking over. Now, there's many reasons that we can explain that, and we can appreciate the lifestyle change because now TikTok, WhatsApp, all kind of interaction, right? They know the word as easily. So meaning as a cardio, we have a really good time to kind of start talking about prevention, before even talking about treatment so we can improve the outcome. So it's part of a neglected non-cardiovascular disease, so to speak. Now, one of the drivers is hypertension. So we know hypertension. Dr. Hernandez is talking about the pregnant women hypertension, so we know hypertension is going to be a big driver. Yet, in the condition where the healthcare is so limited, people are not taking care, okay? So those was at least some of the information why we need to go to the next level of bridging in terms of cardiovascular education to make them aware of what is going on in terms to improve the outcome. So now let's talk about access, which is accessibility. I love this slide because what is happening, we know the healthcare system in many countries, including Congo, is not perfect, but in the same tokens, we have some good facility here. But I cross it, why? Because not everybody is going to be able to afford this place, okay? So even myself, I will not be able necessarily. So look where the vast majority of people are taking their care over here. This is a fragmented care. Something that could be taken for 1 week, they're going to issue 1 day and then stop it. Now, we can take advantage of that to bring maybe the other plant-based medicine. We can bring other holistic approach to just kind of bypass the high cost that's get involved on that. So the other slide is interesting because look the resiliency. Congolese people and many other parts in Africa will get by at least to make it happen, but you see how the delay can be coming up. Now, I like this slide on the right side because if you zoom it, people were having fun say is a president, the previous president gave a gift to one of the country. In a rich country, a lot of mineral, a lot of money, look how they can give that as a token for people to get the help. So me, I will come in with our students, our learners, and our team to kind of bridge that in a way. Now, my solution is going to be more in terms of a visit because I have a clinical mobile unit. We go from now home visit, but in the future, as I finish building capacity, building the space I'm having right now, we see some slide, then we can do field to hospital and hospital to hospital, okay? That's exactly the point I was talking about the Good Samaritan on the floor. You attend first, then you bring to the inn, and then you come back for follow-up, which is a continuous of care. Now, at the end, I will show you just my work in action. Everybody were asking me, Dr. Rapo, if you find something, what you going to do with us? So the answer is simple, yes, I'm attending now, meaning I'm going to build. So that's the reason why I'm pushing forward to get my center up and running in the Congo, because that's what the question. So we're going to be talking about early prevention, early screening, early detection for early treatment and early referral, okay? So this is the part of our job we're doing in the access, okay? So now come here as a faculty Morehouse School of Medicine. We've been working now as a team to develop this model. I see very interesting. So we're going to call it Prototype Project, which is a global partnership to transform cardiovascular education and access in the DRC. So meaning it's going to be collaboration from first part all to Kinshasa here in the United States. We have Morehouse School of Medicine provide all the community engagement, including cross-cultural expertise, including my expertise. Then we have my Global Health Incorporated, I mentioned to you, is going to help with a telemedicine for solution. So, you know, we don't have to bring everybody to the Congo, but we can still work remotely and get the job done. And then, of course, I show you the Archdiocese of Kinshasa and Atlanta have created that group here, networking for us to help. So we've been fundraising for the Catholic University of Congo as a board member, and I will show some of the picture before going. So meaning we are United States, we go all the way to Kinshasa, where Democratic Republic of Congo, where my fondation, this is in French, fondation, meaning foundation, is going to be have expertise on the ground, because that's where we have all the full information gathered. So it's a win-win, as you can see this slide. Our student here, I started for MSN, we're all happy to go there. And then the DRC will benefit. You see, I went there, did my teaching on echo as an extension of a physical examination, a very good concept. And of course, all the partner will be having that footprint as a global health collaboration and partnership, okay? So, should go back here. Yes. Now, this is our structure in the Global Health Institute at Morehouse School of Medicine. I will not reinvent the wheel, so what I will do is bridge with what Dr. Stahl has been doing already in Ghana, because this is a summer program. We can call OSCE one way or the other. Now, I was part of faculty who were testing the cedar medicine we talk about in India. We have now the second cohort going to India to learn that. So meaning if I'm able to bridge that in Congo as well, we have 2 cohorts, one going to India, one to Congo, and vice versa, okay? All about the non-traditional medicine, which is a phytotherapy or plant-based medicine or alternative medicine. So we have a holistic approach on that aspect. Now you see in the middle here, so Dr. Stahl is there, Dr. Kofi Kondwani is here, so we're going to be talking about meditation. Meditation is going to be part of some of the talk. Very easy, can be administered remotely, 20 minutes, and we talk about, so those are the input we as the Morehouse can provide in our global health, and the leadership, as you can see, Dr. Graham over there, and then the team here. And then the one not picture. Now, of course, I was the one, as the idea came to go to Congo, we created with our student, the first group, Jenny, and Melissa is in Malawi, Jenny now is in India. I was the leader, say, okay, Dr. Lap, we have a student for Africa, but we don't see a student for global health. Let's do it. And then we decided we created that global health interest group. Me as a mentor, I continue to be their mentor. Here we are. And now this is one of the students, she's finishing this year, and for saying we can provide the process of fundraising and so on, and the selection, so to speak, and the global health. Now, before going to test my concept in the Congo, we play with our student here, MSMS, meaning what? This is our next generation. They're going to be receiving the first-class education here, first-class experience going there. This is a different culture. We're not talking about English-speaking country. We're talking about French-speaking country. So meaning, even if they don't know French yet, same thing in a cultural sensitive medicine at Grady. Some patients come, you cannot talk with them. You'll lose some sort of interpretation. So investors are asking me, Dr. Lapo, make us to work. Whether you want to use a watch, a clock, something to make interpretation, a device, give us some work for us to build. So we're going to challenge our new generation. As you can see here, we're having fun to do that. So the other model was, for instance, she's now rising MD3. She was part of this group, say, okay, while we in the Congo, another group can stay do a telemedicine. Now, Irtha, she speaks French, she's from my country, she's here, so it's a model we can use easily. While she's here in the United States, we in the Congo, we're doing some sort of interpretation, English, French, and all kind of other language from our hometown, because we have many languages, okay? So that's a good model. We're testing that day before me going to the Congo. Now, this is our chief of internal medicine, Dr. Snyder, said, Dr. Lapu, we're going to go past student. We need to bring intern, resident, even fellow for cardiovascular fellowship at Grady and our Department of Medicine. So meaning we have a student summer program type of Dr. style, Dr. student India, but we still have another model of intern going for 1 or 2 weeks with me, okay? So we go there, that's the idea of Dr. Schneider for internal medicine, said, Dr. Lapu, you can bring the student in rotation 1 to 2 weeks. I teach all the fall here. So meaning between fall, when I'm done for all the teaching across the board, I will go May, June, July for our student. In between, go with our resident intern fellow. Now, Dr. Onwani, chief of cardio, said yesterday, Dr. Lapu, don't let me behind. I need to go with you. Dr. Dewale Cardio, many people want to come. Of course, we're talking about learner stuff and people come together to build that story. We good? So now the other partnership out of United States, let's go now in the Congo. So I was trained in University of Kinshasa, which is academic public university, right? Now we have academic, but the private Catholic, I already mentioned. Some of my colleagues, we finished the same, he was in France, as GI, and now he's back in the Congo. He's been doing a lot of good stuff from France to, as a GI guy, he has his own clinic so we can work together. So a few slides for you to see. Those are the board, as I mentioned, the Catholic University of Congo, both Archdiocese of Congo, Kinshasa and Alanda have created that model where we're serving together. And then for now, he's a priest, he's the guy who, Dean, is at Emory, he's a psychologist. And then this is a Delta pilot. This is a doctor, family medicine. Her husband is a cardio at Emory, so we work together. I'm at Morehouse School of Medicine. So we provided that bridge to support the Catholic University of Congo, and that makes sense in our model, MSMS, RL Access Medical, FOCUC, and then go to Forilas in the Congo. That's the beautiful model we can provide. We just finished another meeting a few weeks ago here, talking about my project as we go into Congo as well. Now, I went to Kinshasa. Of course, that's University of Kinshasa. As I mentioned, I was talking about POCUC, point of care ultrasound, which is a new concept. You can use that in extension physical examination. So non-invasive, handy, non-bulky. You can do it everywhere. You don't need the MRI. You don't need the CT scan. You can do the job. You will see some of my slides to just point it out. And then you see the students were so happy to get a picture of me because they've heard a lot about me. Dr. Lapo was here, now in Belgium and United States. So when I'm turning back, it's a good model for them. Now, I will work with a partner like NGO. This is where one of my ambulance was sitting, so most of my equipment are in this place. So here is a non-profit clinic as well. Last summer, 24, you can see May, I was there. Now, this is my colleague. I mentioned that the GI left France, is now in the Congo. A lot of good stuff, university. This is a private practice. So I went there with a fellow student, resident, so meaning our students have a really opportunity to interact with these beautiful, wonderful people here. They're excited to see me here. And then we went to a patient room, and then I was talking about the EKG, they mess up the lead, and then I was asking them a question. They love that interaction. So here we're in a private practice with my classmate now from GI to here, so we can work together in his business, okay? Here we're talking about Mamayemo. Dr. Graham have this hospital close to William B. East. It's one of the reference, the big hospital in the past. It has been renovated. In 2023, I went to the ICU. You can see here I'm interacting for the student, and we were in the ICU. Those are the slide video, but I don't want to play them because I don't have time. When I do the presentation, you can see me talking, do some very short clips. And then the same thing, I returned last year. Here we are. This is the guy, Dr. Roger Kokus, is a cardio. He was trained in Morocco while I was in Belgium. So now we're together. As I'm here, is the guy's going to make a connection to cover my activity. So we do telemedicine. Every time he sees patient in Congo now, send me a picture, call me, we talk, and then make some direction. Is learning, of course. And now we are here, so I went there. You see, this is a lab coat. This is lab coat. He gave me this lab coat. He gave me a stethoscope. I didn't bring my firm stethoscope with me. And then we went in a room. You see my teaching, so they love teaching. They love my teaching because, you know, when I'm on the floor, teach, you cannot stop me, okay? And then it was fascinating to learn, too, as a cardio. Said, Dr. Lapo, you're my classmate, but what you have achieved now, I can learn from you. See, we can provide a lot of good things here because you can see here now, this is a patient. I cannot play it. Is actually. So this is a patient. You can see here. I cannot play that, right? Okay, that's fine. It's a small video. So she's been very sick, this patient. A month ago, when I came from United States, the trip, I went to visit this patient. She was almost dying here. You see here, I'm taking, look at the setting. It's not the setting you used to see here. This is a reference hospital, okay? Now, look, people are on the floor. People are sitting, laying down here. I am there. They're doing all kinds of things. Look, patient all over the place. And then this was, I spent from 8 p.m. all the way to the next morning. She was almost dying. I mean, we were able to pull this patient out in a miraculous way. And then you see the family sit down outside. They sleep outside. This is a big hospital. That was the name of our former president. So look at the job we have to help this individual. They're sitting outside. I was so concerned, and the patient sitting there, we're trying the best to get her out of trouble. Okay. Now, I'm going to go now to show just a few videos or a few pictures to close. Phase 1 is a phase where I didn't start ambulance yet. Okay. So for the next slide, access is in action. I want to play this. They love the idea. This is the news, the Catholic news. There is no sound. Is sound? Don't worry about French, okay? Just see the picture. So I'm doing echo. 250 patients coming from everywhere. I did. This is the priest. This is a parish Saint Anne. Mm-hmm. So I did the consultation. I did the care. Mm-hmm. So here, this is a priest. Now is the priest is gonna be do some business there. So they were happy because I was there. Look, all my equipment, non-invasive. So now we went to the church. Yeah. This is a mass. After that, so did the church, they're receiving me. This is the priest. So it's talking about the good business we'll be doing there. He's coming from far, United States, in Atlanta. Where's the sound? So he's talking about me. So it's a free consultation. It's happy, okay. We're going to move. So what was the business I did here? So you see all the people with a disabled individual. I did all the echo. Now, this is one of my first tests to go in a VIP guy. You can see people are getting bigger. The reason may be hypertension because people lifestyle have changed. We good? So I do EKG, all portable in his house. Look, it's stable, full of food, this guy. Is in a government. I went to people's house. I went to the private practice. This is one of my classmates. One of his patient, I was seeing him as a cardio remotely. And then when I see everything, we follow up. Now, I went to the higher place of training of our military to see all these guys. And I went really in the middle of the jungle somewhere to do echo in the people's house. You see, this one just passed away 2 months ago, heart failure. He was a family member, okay? So here we are, all this individual. Okay, now phase 2, now the ambulance come into play. So now in the phase 2, I ship ambulance, as you guys can see. I roll my sleeve. My model is easy. I'm not a star sitting somewhere in the office and have a lot of money sent to a guy to open the center. I'm the one coming just to open my own clinic. So you see, we ship it. So the last one is just few, let you finish. So this is the ambulance. I'm in the jungle. That's it. And then we have in the church, we can move. The idea, you come sad, you leave happy. I'm explaining to Dr. Shridan here. And then we're going to finish with here. The generals, I do the same concept. So here I'm doing really in action. This is the first general. The patient wanted to make sure that is him. And this is echo. So I do echo. First, the consultation. I will go faster. Those are video. They were scary. So you see, I'm seeing all variety. Take history, vital sign, physical, and then do echo and counseling. And then we're going to move that. And then I went to the church, another church in the countryside. And then here in the church, look how people are happy. We're dancing, and then people are lining up to get screen. So here they're getting screen. And then I do the same thing. And then I'm building this place. So the priest and I I bought this land. I'm going to build a medical center, so we have care and ministry of us, so both. The Lord is the great physician. Me, I'm providing care, and the Lord is the one who heals. So it's a good model together. So that's why I bought this land to build here. We're going to finish. Okay, here we're building bricks. And kids, just now 500 miles away from Kinshasa, look at the kids, they're lining up. The same concept. And then we're going to finish here. Okay, should I point this way to move it faster? It's not moving. Okay. I want to show just the Ghana. It's not Ghana project, and we're done. Okay. Anyway, so I want to show. So now, Dr. Sal and I, we work with Ghana. We're good to go for our next level.
Don't go yet. When I listen to Dr. Lepu's story, I think of a thought that always comes to my mind is that you must never underestimate the power of one, because you must never underestimate the power of you, the difference that one person can make. This is just a wonderful example of that. Thank you so much. Merci beaucoup.
Merci beaucoup.
Our last panel today is our learners panel. So providing learners, our students, our faculty, our residents, and our staff, global learning opportunities is a major goal of the David Satcher Global Health Equity Institute. You have heard today about the students who are in faculty who are in India, those who are in Malawi, those who just came back from Costa Rica, right? So what we want to share today are those stories. We know that such a global learning experience and exposure makes one a better health professional, more caring, more culturally competent, as Dr. Vincent said today, with more cultural sensitivity and structural humility, a better health professional, a global citizen, and in reality, a better person. So we'd like to ask Dr. Gigi Bastian to come up to share with us and our students and residents who are in the room to come up and share their stories. And this is what it's all about at the end of the day, ladies and gentlemen.
Could not agree more. Thank you, Dr. Floyd. This is what wakes us up, gets us going in the morning, is as my incoming grays in my front edges remind me, I will not be here forever, so we get excited about our learners who will carry this work forward. So I want to welcome Carl Opara and Dr. Chantal Kaiser up, who will join us. And we're just going to get right into some dialogue. So we wanted you to hear directly from some of our learners about experiences that they've been having and how that is shaping their perspectives as evolving leaders. You can take a seat. I'm going to stand because I've just been seated for too long today. And we will start from the beginning. Who are you? So everyone has your bios in their booklets, but wanted you to begin by just sharing a little bit about your background and what inspired you to want to pursue global health experiences as a part of your training at Morehouse School of Medicine. So let's start there.
Okay, hello everyone. Hi, Dr. Lepu, how are you? My name is Carl Lopara. I'm an MD1 student currently at Morehouse School of Medicine. Before then, I was actually in the Master's of Science of Medical Sciences at Morehouse School of Medicine, and Dr. Lepu was actually my advisor, so it was great to see him today. I actually wasn't expecting to see him here. I was born and raised in Beaufort, Georgia, and have decided to pretty much live here for most of my life. My interest in global health, I've always just read a lot about different aspects of medicine that are outside of America that I'm always just like, well, why don't we do that? Like, this seems like they kind of figured it out over there. And this trip that we went on to Costa Rica was like the first time that I got to actually see what medicine looked like outside of America firsthand for the first time. So, you know, out of the reading and into the actual culture that is different. And so, yeah, I hope to continue to be a part of more trips and bring back some of the things that I got to see firsthand and tell a lot of my peers. I've been fortunate enough to be able to tell a bunch of different stories to a lot of my classmates that were very interested in everything that I had to learn while we were at Costa Rica.
Carl, what about for you, Dr. Kaiser?
Hi, I am Chantal Kaiser. I am a pediatrician in my previous career, I should say, and I decided to...
A little closer so we can hear you.
Okay. I decided to transition into public health, so I am currently a final year preventive medicine resident at Morehouse School of Medicine, and I'm also a final year MPH student. As you can probably tell, I have an accent, so I'm from the Caribbean originally, so a developing country, St. Vincent and the Grenadines. And so growing up in the Caribbean, I got to see how healthcare is very different. And I always had this idea that everybody deserves access to healthcare. I just never knew back then it was called health equity. But I do believe everybody should have healthcare. And so when I was at Morehouse, I sought out the Global Health Institute, and I was very grateful to be able to partake in going to Costa Rica.
Excellent, excellent. Thank you both for sharing what sort of brought you into these experiences. And Dr. Kaiser, you actually touched on a point that I'd love for you to share more about with our audience, which is how the experience that you had in Costa Rica and any other global experiences you've had during your time with us at Morehouse is impacting and shaping your understanding of health equity and what it means and what it looks like. Would love to hear your thoughts on that.
So Costa Rica was an amazing experience culturally, and I think when you are going to immerse yourself into another person's culture, you really need to be aware of yourself and then learn that culture. But in Costa Rica, everyone there had this concept of what they call pura vida. And that was one thing that stood out to me. They were always very humble and very happy no matter what. The healthcare system there was what stood out to me the most. They have a system, what they call the bias. I cannot translate for you what a bias is. Dr. Bastian probably knows the Spanish version of it. And it's a phenomenal system where they put a lot of emphasis on preventive care, and so their outcomes are a lot better than us. And if you look at where they ranked in worldwide for their health outcomes, they actually are much better than the US. So that was a great experience for me with that.
So much for sharing that. Carl, what about for you as you kind of reflect on the time in Costa Rica? How is that continuing to impact and shape your thoughts on health equity?
Well, I think that was a great response. And just to add a little bit to it, I think also looking at how much the people of Costa Rica in general, they care a lot about health in general. So that's providing all kinds of health, but specifically primary care. Looking at how much it is implemented in a lot of their policies and their politics. How much funding goes into all of the programs that they're able to have so that everybody does have access to primary care. Also, something that was unique with Costa Rica was looking to see how everybody kind of has a team of healthcare providers that are looking over certain populations of people within different sectors of Costa Rica. So they have people that are checking up on them, you know, the social workers that they really emphasized were an important aspect of care, just to make sure that people are going to appointments or figuring out what are the different barriers to them not being able to even get there in the office in the first place. So it's really seeing their patients as people holistically.
And I'd just like to touch on a little bit on what Carl mentioned. The ABAIS system is, as Carl mentioned, it has a social worker, a doctor, a nurse, a pharmacist, but they also go out to patients in the rural areas as well who cannot get access to come to the clinics. And that stood out to me as well, that they go to their patients no matter what. The other thing in Costa Rica is that they truly believe everybody has a right to health care, every citizen, as well as non-citizens. So you will see in Costa Rica a lot of refugees that will, on their way up through Costa Rica to the US, will stay in Costa Rica for a little bit, but then they will have access to care. Even us visiting, if something happened to us there, we had access to care as well. But their gatekeeper system that they have with the ABAIS was what I think how they managed to control costs, which was very interesting. If you lived in the north, for example, your ABAIS is there, you're not going in the south. But if you needed emergency care, if you were visiting the south, you had access to the south. So that to me was how I thought they controlled costs, and that was great.
Thank you both for highlighting, I think, such a great illustration of what we've been talking about in terms of the value proposition for thinking global and having that global perspective, because I think for so long the idea has been that when we engage in global health work, it's about us kind of coming in as experts and bringing what we have as though we are the holders of all the solutions and expertise. And what you're articulating beautifully, I think, is the rich opportunity we have to learn from so many other parts of the world in terms of the systems and processes and approaches that they have in place that could be just as beneficial and bring win-wins for us if implemented here in the US. So I wanted to sort of backtrack a little bit to set a bit of context before I ask my next question. And we actually will come back to hearing from a voice that couldn't physically be with us here today. But to give a little bit of context for folks, it was a team of 12 of us who spent 10 days in Costa Rica. And so, as I mentioned earlier, it was an interdisciplinary, interprofessional mix of our students, including our MDs, residents, public health students, a few of our students in our graduate education biomedical sciences programs. And there they had an opportunity not only to be educated about what you hear them speaking to in terms of the system of care there, how it's structured, how it's implemented, who is a part of healthcare, who's the workforce, what does that look like. But importantly, as Dr. Vincent sort of alluded to this morning in her talk, so often when we're talking about healthcare, it looks more like sick care, right? In how we're managing illness and breakdown and when things go wrong. And one of the rich opportunities this group had was to really learn about a unique feature of this society, which is, I don't know how many folks are familiar with the blue zones, and you've maybe seen the Netflix documentary about these 5 areas of the world where there are high concentrations of centenarians, of folks who are living past 100. And scientists have been looking to learn what are the secret ingredients, what are the key features of life in these environments that is leading to the longevity that we're seeing. And so they had an opportunity to travel to one of those regions in Costa Rica, Nicoya specifically, where they had an opportunity to meet a couple of those centenarians and to learn about what is it about how folks eat, how they move and remain active, what is it about the social environment, right, that is creating the perfect atmosphere for living long and healthy lives, right? So as I say all of that, I'm asking all of you, because I was there with you, and Media, who's back there, I looked at you, Media, when she mentioned Pura Vida, which we decided we should all get Pura Vida tattoos by the time we were leaving Costa Rica, which speaks about this philosophy of life that really captures the essence of the place. So when you're there and you're hearing all of these accounts, whether it's from the healthcare professionals we sat with, from members of the community, you're really inspired and you're thinking about these things. But as you get, a month out, 2 months out, a year, would love to hear your thoughts about how we can continue to ensure that those experiences have long-standing impact for our students. Would love to hear what you think are the key ways that we can help support kind of that long-lasting impact for our learners as they're going into these experiences. Any thoughts around that?
Well, from a student perspective, still in school, so, there's certain things that we're focused on and working on, but one of the takeaways for me that I definitely, we're not there financially yet, we don't have certain aspects of power policy-wise, but we can be very much well invested within our communities within Atlanta. And so community building is a pillar that I am kind of taking with me with all of the other organizations that I'm a part of, investing back into Atlanta and seeing what our different communities need. And so that's something that that I can do as a medical student, and I can kind of guide some of the other med students towards not just being in Atlanta and studying and worrying about what we have going on, but really being invested with the area, which is something that we see in Costa Rica, and especially in the Blue Zone area, that contributed a lot to their well-being and their health in general.
And in addition to the Blue Zone, they talked a lot about having a purpose for life. With regards to what I think as from a resident point of view to continue, it's engagement, to be engaged with global health institutes, as well as I think curriculums can be developed throughout residencies, because due to globalization, you are going to have a lot of communities from outside of the US, in the US, and you rightly pointed out that there is about 60 different cultures here in Atlanta. So I think we need more engagement and involvement from that standpoint, from education with our GMEs.
Appreciate your thoughts on that. And we're taking note in the Institute because we're very interested in how we continue to build on these experiences, right? Dr. Kofi Kondwani, who's here, has been leading some work in collaboration with some of our Fogarty partners that is really interested in why we sometimes see a hesitation among underrepresented minority students in participating more in global health. And the award that you heard Dr. Glass announce this morning, for those who are here, he shared that we just received some funding to be able to create opportunities for these shorter stints of sort of dipping your toe into the global health sphere, right? Similar to what you all experience. Because for some of our learners, if you haven't had a background of traveling all the time, Dr. Ginger Floyd is on a campaign to get all our students to have a passport, at least, right? Some of our students come in not having a passport, not ever having gone anywhere before coming to Morehouse. And so the idea of doing what Melissa is doing in Malawi of a year, and we're gonna get to hear from her via video here shortly, can be daunting, can seem overwhelming, right? And so how do we create these opportunities of varying lengths, give students a couple weeks to get an experience, give students like our delegation that's out in India an opportunity for a month to get a little bit more of an opportunity to see what things look like in the clinical sphere, on the research lane, and through a public health lens and so on. And so I'm wondering what advice you would share maybe with your colleagues, other medical students, residents, et cetera, who may have some sort of vague interest in this space but not be sure in terms of where to start. What would you share with them in terms of how to find opportunities in global health?
I would say always keep asking questions. Seek out mentors in your institution. So when you do come to an institution, find out what they're about, their mission, who's there, and don't be afraid to reach out to people and start there.
Yeah, exactly that. Connect with the faculty, connect with people that are part of the Global Health Interest Group, see what they've done before, if you could follow in their footsteps, if there are things that you are interested in that hasn't been done at Morehouse yet, how we can work on getting that to be a part of Morehouse School of Medicine. You know, that's if the Costa Rica trip wasn't funded, I'm pretty sure my parents would be like, Costa Rica, like, you work on your loans, you know, something like that. But fortunately, you know, because it was funded, people, you know, regular students like me were able to go. And that really was very appreciated.
Y'all are amazing. Thank you for sharing your thoughts. I did want our audience to have the benefit of hearing from one of our learners who couldn't physically be here, and we couldn't quite get her in on Zoom as we had hoped. But Melissa Issa Bouvet is currently in Malawi as a Fogarty Fellow. And so via video technology, we will get her in.
Is originally from Niger in West Africa. My mom connected me with physicians in the area, so I got to see how healthcare was practiced in Niger, and those experiences illuminated the disparity. Opportunities that I've been engaged in while here at MSM include the creation of GIG, which Jenny and I co-founded during our first year. We worked with Medshare, Books for Africa, we worked with Jolly Garden, we worked with Meals on Wheels, and also at the same time trying to find global opportunities for students. So I was able to apply for the Fogarty Fellowship and travel to a country for an entire year to carry out a project related to global health in a low-income resource country. And Jenny, on the other hand, she's in India now, and so she's taking part in the India Way elective. Here in Malawi, my project is looking at the gap between the amount of blood that is requested by the clinician and the amount of blood that the patient actually receives. So the hardest part about working in Malawi is experiencing firsthand the disparities and seeing how healthcare is practiced. The only difference between me and the patients is that I just happen to be born in a different place. This makes me mindful about how healthcare is practiced and what I can personally do to change healthcare practices that better benefit patients without implementing my own views that have been trained in a different healthcare system and adapting what I learned to better fit the patients that are in this context. This impacts my understanding of global health equity because I remember a physician saying that if you vaccinate an entire village but children are still dying of malnutrition, have you done your job? And so it makes me think about the work that I do. Is it sustainable? Is it helpful even? I don't want my temporary position to negatively impact the populations when I leave. To make sure that these initiatives are action-based, and I mentioned how GIG was very adamant about making sure that we have at least one volunteer event a month. The real work and the real impact happens when you're actually on the ground and in the community and doing the work. So lastly, we can't talk about global health traveling without discussing the costs. I know that finances are a barrier for many students, and if we are able to remove that barrier, at least minimize that barrier for students, I know that that will encourage more people to go and engage. I have to join GIG because GIG is a great liaison between the student body and the faculty that engage in global health here at MSM. I say that GIG has led to me being in Malawi here today. I would encourage students to take risks. I'm sure you can imagine that my parents were not too enthused about me extending my medical education for another year, but once they found out the reason and the purpose, they knew that this was on brand for me, and it's really broadened my world about what is possible and what is not possible in the short term. And so it's given me a much more realistic picture of what I can do as a surgeon. The hopes that I have for a global health education at MSM, more students going to the away electives that currently are in India, but it would be great to also have something available in sub-Saharan Africa or South America for students. I would also like to see global health addressed in our community health course, and I would like to thank the David Satcher Global Health Equity Institute for all of your support. Thank you so much for having me. I'm glad to be able to participate in this summit all the way across the world.
Okay, so I think we may have time for a couple questions, one or two, if folks would like to ask something of our learners. Any final thoughts for us, y'all?
I would just love to say thank you very much for the opportunity. It really did fuel my passion for pursuing global health after I'm finished with my residency at Morehouse.
Thank you for the opportunity, of course. A lot of students are very much interested in other future trips. They're already asking me, so I'll be like the liaison in a way. So just looking forward to what we do in the future.
Also, I would like to ask, is there opportunities for research?
All day, all day. See us after this session, all sorts of opportunities, and we'd love to have you engaged in any and as much of that as you can manage with your other responsibilities. The morning half of the day spent a bit more time around research, but yes, opportunities for our students in research and service and everything in between. So thank you both again for agreeing to share your experiences with us. Please join me in thanking our learners for sharing their stories.
I'm going to be brief, but I just want to wrap up the day's events because I think what you've seen is that there is so much need, but there's also so much opportunity. And we have a whole universe of fertile young minds and service-oriented people to carry out this work. And it's really the students that will make the changes we need to see in this world. The other major thing I want to leave you all with is that we need to decolonize the geography, but we also need to decolonize the minds. And that listening is what we need to do first. Listen to know what the needs are and not impose our own ideas and thoughts on people who we are supposedly trying to help. So I want all of us to think about listening. I want you to prepare for coming back a year from now when we have our Global Health Equity Summit on the 50th anniversary year of Morehouse School of Medicine. There'll be an all-year celebration for Morehouse in general, but we're going to add the summit as one of those celebration points. So think about sharing this experience with your network. We want to see at least triple the size of the audience next year. We want to do it together, face to face. I think that changes things. And I also want to thank, I don't have time to thank everybody, but I have to thank Rosalind Blackwell, Zipporah Dorsey. These two have gone without sleep for the last several days to try to get the logistics of this together. I want to thank the Gathering Spot for the wonderful AV work. The food was amazing, so thank you for that. The space is perfect for this. And I want to thank the Marcom people at Morehouse School of Medicine. If any of you are here, please show yourself because you all helped get the word out and make this all possible. I also want to thank my wife, Cynthia, Dr. Turner Graham, who may not be here right now, but she, she keeps me grounded. She makes me clear that there is no health without mental health. And I'm a recipient of her mental wellness training over the last 45 years. So thank you to her. Thank you to all of you who stayed and participated, and thank you especially to the students who contributed to this. So thank you, Gigi. All right. See you next year.